All right, good morning, everyone. I'm Susan Yanofsky, and on behalf of the NIH Obesity Research Task Force, I'm delighted to welcome you to our symposium today on obesity and heart disease. Before we get started, I would like to take care of a few housekeeping details. First, I want to let you know the webinar is going to be recorded to view at a later date, and a copy of the recording will be published on the NIDDK website in about a month. So if any of your colleagues weren't able to make it today, they will be able to see this later. Attendees will not have access to their cameras or audio. All videos should also remain off, except for the speakers. Live captions can be turned on by clicking More at the bottom of the screen and then clicking Captions. Please submit any questions or comments to everyone using the chat function located at the bottom of your Zoom screen. I want to point out that you'll see a Q&A, but the Q&A is disabled. So go to the chat instead. Anytime you think of a question during the talk, feel free to put it in. And at the end of each talk, I will be moderating and looking at the questions of the chat and reading them to the presenter. We're also going to be having a panel discussion at the end of the symposium, so that you'll have an opportunity to ask more of your questions then. And at this point, I'm going to turn things over to Dr. Donzi, who I believe is going to introduce Dr. Gary Gibbons. Is Dr. Gibbons here, Laurie?
I'm not sure. That's what I was looking for him, and unless he's in the other webinar room. So
oh, that's a good point. Janaya, can you monitor the larger room and see if you see Dr. Gibbons there, and if so, unmute him so that he can talk?
Yes, unfortunately, I am not able to find Dr. Gibbons. I'm sorry.
All right. Jamie Smith, I see you're on. Do you think you could do a little troubleshooting?
I don't see Dr. Gibbons. So,
right. Do you think you could text his office? Because what we can do maybe is get started a little bit early with our first talk, and then hopefully find Dr. Gibbons and get him on the correct link.
All right, Sadiya, it looks like you're going to be up a little bit early this morning then.
Well,
I'd like everybody to help me welcome Dr. Sadiya Khan, who is the Magister Professor of Cardiovascular Epidemiology and Associate Professor of Medicine and Preventative Medicine, the inaugural Director of the Center of Population Science and Aging, and a preventive cardiologist at the Northwestern Feinberg School of Medicine. Dr. Khan's clinical expertise and research focus on health disparities, risk prediction, and cardiovascular disease prevention. Dr. Khan's research efforts are supported by multiple grants from the NIH and the AHA in collaboration with the Doris Duke Charitable Foundation. She's an associate editor at JAMA Cardiology and serves in key leadership roles within the AHA-ACC, including serving as the chair of the AHA working group that developed the PREVENT equations, the chair-elect of the AHA Heart Disease and Stroke Statistic Committee, and a member of the ACC-AHA Joint Committee for Clinical Practice Guidelines. Dr. Khan's talk today is entitled The Epidemiology of Heart Disease in Persons with Obesity. Please help me welcome Dr. Khan.
Thank you, Eric, for that very kind introduction, and really excited to be kicking off this webinar. I think, we have come a long way in terms of our understanding of cardiovascular disease in persons living with obesity, and hopefully over the next 20 to 25 minutes, we'll be able to understand what the epidemiology has taught us and set the stage for the rest of the day. I hope for exciting therapeutic interventions for perhaps improving outcomes as well. I have no relevant relationships with industry and funding as mentioned. So before we get started, I think there has not been a greater focus on obesity than there has been in the last several years, but it's not a new problem. This is an advertisement from 1940 that I was looking through Google trying to see if I could find something that was interesting. And it's really, really not changed in terms of the types of advertisements that exist out there. And I think especially this idea that there could be a quick fix, right, in terms of finding a way to lose a few pounds, slim while you sleep, surely and safely. Not that this is necessarily the fix, but the idea or concept on prioritizing weight loss or health through different mechanisms. We're going to cover 4 key objectives today. First, focus on the trends and drivers of obesity in the United States, talk about the burden of cardiovascular disease, its subtypes, and also cardiovascular-related conditions that are obesity-specific. We'll talk a little bit about the novel American Heart Association construct of cardiovascular-kidney-metabolic syndrome and how it relates to cardiovascular disease risk and obesity, and conclude with some future directions, controversies, and projections. So in order to understand where we are today, I thought it was helpful to take a look back and think about where cardiovascular disease has come in the last 100 years. If we look at mortality rates, these are unadjusted mortality rates per 100,000 population starting in the 1900s. Of course, that large spike comes from the flu epidemic. We see that heart disease was starting to rapidly increase in the 1930s and 40s, largely coronary heart disease. And at that time, a national leader in heart disease, Dr. Paul Dudley White, was quoted as saying, "We know the hypertension management is an important compensatory mechanism and should not be tampered with, even were we certain we could control it." And so we've come such a long way in terms of our understanding of management of hypertension. And I think we're seeing that same evolution now for obesity. And we're still in that phase of how we manage, how we treat, and should we treat. Fast forward over the next 20 or 30 years, we see this evolution of heart disease mortality starting to decline. The Framingham Heart Study is commissioned and the term risk factors themselves are coined, and in this seminal paper to have us better understand what are the contributors to heart disease risk. It's around 1978 when this observation that mortality is starting to decline and has been consistently for several years, that the first Bethesda conference is called, or not the first, but a Bethesda conference is called to look and understand if this 20% decline in coronary heart disease mortality since 1968 is real, what the potential causes are, and to recommend further studies to elucidate the causes. And this really helped to contribute to a lot of the population-based cohorts that we see that have since informed the epidemiology of obesity. If we keep moving forward, though, unfortunately, there comes a shift in about 2011 where the continued decline in cardiovascular disease mortality, and similarly for ischemic heart disease mortality, faces a plateau. And then there is a bit of a reversal. And what we see when we look at cardiovascular disease subtypes is that that reversal occurs with an inflection point, particularly for heart failure mortality, where all of a sudden we're starting to see an increase in heart failure mortality that is contributing to the plateau in overall cardiovascular disease death. And this led to a follow-up Bethesda Plus 40 conference that was the follow-up to that 1978 conference under David Goff's leadership, where we met to discuss some of the potential contributors. And one of the things that kept coming up over and over again was really the obesity epidemic. And how has this, over this same period, consequentially, really contributed to the changes that we're seeing now? So if we take a look at the prevalence estimates for US adults of obesity, we see graphs like these from 1960 to 2018 showing really rapid increases in obesity prevalence. We have estimated now that the prevalence of obesity has increased from 31% to 42%, severe obesity from 5% to 9%. And this translates to more than 100 million adults living with obesity and more than 22 million adults living with severe obesity. So really rapid and striking changes over a relatively short time period in the last several decades. These maps are familiar to, I'm sure, everyone in terms of the prevalence of self-reported obesity from the BRFSS survey by state, over time. And you can see on the same scale from 2011 to 2023, that marked reddening throughout the country. While one thing that I think is really important to notice is that the states that have the highest rates of obesity, Arkansas, Mississippi, West Virginia, to call out the top three, continue to be the highest, and they now exceed 40% in 2023. If we look at differences by race and ethnicity, we again see disparities with the highest rates of obesity among those who self-report as non-Hispanic Black, and that's true among men and among women. What's interesting is that reporting for Asian Americans has largely been done in an aggregate group, but we know that there are significant heterogeneity among disaggregated Asian subgroups, and this was a really nice paper that was published just a couple of years ago, led by Nilay Shah at Northwestern, looking at disaggregated Asian groups and showing the heterogeneity in obesity prevalence across the groups, which are lost when aggregated and categorized as one group as Asian. We see very similar things when we look at disaggregated Hispanic groups, and really pushing this idea that we need to better understand the intersectional social factors that may contribute to these differences. If we look also at educational attainment, I think this is another key social factor where we see large differences in obesity prevalence. We see differences that range from 20% for a college graduate to over 40% for rates of obesity. And these are similar patterns are observed by household income and other social factors as well. So really wide spectrum here. I think this is not only important as we think about the prevalence and epidemiology of obesity, but as we start to think about implications for therapies that we'll hear about. Obesity and obesity-related cardiovascular diseases, particularly the novel therapies on the horizon, are expensive. They're going to require healthcare access, higher levels of healthcare literacy. And so this is also going to be an important factor that we need to contextualize. Unfortunately, the curve for obesity prevalence among U.S. youth looks very similar to the one I showed earlier for U.S. adults, and we're seeing really rapid increases in the prevalence of obesity, with 19% of children aged 2 to 19 having obesity, severe obesity at 6%, and overweight even at this early age at 16%. All of those data that I've shown you have been serial cross-sectional snapshots, but even when we look within the same person, and this is really nice work that has been made possible by the CARDIA study, the coronary artery risk development in young adults study, which was initiated right at the beginning of the obesity epidemic in 1985. And so coincidentally has followed a group of about 5,000 individuals who have really lived through it with repeated BMI measures. And we see even at the individual level, this continuous and repeated increase from cycle to cycle of the CARDIA field visits of continued increases in BMI. And when stratified by race and ethnicity, we see the greatest burden among Black women, but similar patterns across this between the ages of 25 and 55. If we think about the exposure to cumulative or lifelong obesity or adiposity, we're going to see a huge increase potentially of risk for cardiovascular disease in the coming decades. So hopefully I've convinced you that the trends are showing really unfavorable patterns, but what do we know about what this means or the implications for cardiovascular disease and risk of cardiovascular disease? In a paper that we published just a few years ago, we looked at 10 pooled cohorts from the National Heart, Lung, and Blood Institute observational prospective cohorts and had about 190,000 individuals with over 3 million person years follow-up, and looked at the cumulative incidence of cardiovascular disease across BMI categories. And you see this consistent and graded response over long-term follow-up with higher lifetime risk for cardiovascular disease with greater BMI. When we look at the hazard ratios, we again see this stepwise increase, even adjusted for competing risk with the long-term follow-up, of a 30% higher risk, 80% higher risk, and then more than 200% higher risk for cardiovascular disease for overweight obesity and severe obesity. One thing that was really interesting was when we actually looked by the type of cardiovascular disease, the type of cardiovascular disease that stands out the most for obesity-related complications is heart failure. And I think this is going to be really important when Dr. Borlaug tells us a little bit more about heart failure with preserved ejection fraction, this really marked increase in the risk of heart failure among those with overweight, obesity, and severe obesity is similar for men and women. I'm just going to give a little bit of a snapshot because I think this figure is really a nice synthesis from Dr. Powell Wiley's recent American Heart Association scientific statement talking about obesity and cardiovascular disease, and shares the complexity of the multiple interrelated pathophysiologic pathways that lead to heart failure with excess or dysfunctional adiposity or obesity. And I think this highlights why this has been such a difficult challenge in order to prevent and manage, particularly for heart failure with preserved ejection fraction. And as we think about the multi-organ involvement, I think this also sets up nicely the idea that we need to think about more cohesive and comprehensive constructs than just thinking about individual risk factors alone. What about the impact on morbidity and years of life lived and burden of disease? This was a study where we looked at the Chicago Heart Association Detection Project and actually quantified among those based on their BMI in midlife, what was the burden of comorbidity, so years lived with comorbidity based on Medicare linkage, based on the Gagne score for all-cause or cardiovascular outcomes, and what was the total life expectancy. And what we saw was that on average, people with higher BMI or with obesity lived up to 1 to 2 years less and lived with greater number of years with morbidity. So the burden was both on quality of life as well as overall life. This also translates to excess costs. We saw that the cumulative costs and mean annual costs for individuals in this sample was much higher with higher BMI. And shown here are the quantile regressions of the 25th, 50th, 75th, and 90th percentile. But those excess costs were consistent, and highlighted were the median excess costs, both on a cumulative basis for total follow-up in Medicare, as well as annually. We also know that obesity precedes cardiovascular disease risk factors, and as well as risk enhancing factors like adverse pregnancy outcomes. And we're going to hear a talk later specifically about pregnancy-related complications. But I think the important piece about this is that obesity is one of the most upstream factors in terms of adverse pregnancy outcomes and cardiovascular disease. We know there's an emerging literature base that is helping us understand that adverse pregnancy outcomes themselves are a risk-enhancing factor, and they're associated with, as shown here, hypertension, hyperlipidemia, and diabetes in this analysis from the New Mom to Be Heart Health Study, which is an observational cohort funded by NHLBI of about 4,000 individuals that have now been followed for 15 years, and show that the association between adverse pregnancy outcomes and cardiovascular disease risk factors is really instigated by obesity or weight before that first pregnancy. If we think about what this means for intergenerational transmission, there have been some really nice studies focusing on the long-term implications of this. And this, I think, is a really nice conceptual diagram that helps to highlight that pre-pregnancy obesity or excess adiposity in pregnancy contributes to excess gestational weight gain and has implications on the offspring and multi-generational transmission of risk, which was also seen in this study from the HAPO multinational group, which looked at cardiovascular health parameters broadly and plotted the maternal cardiovascular health categories and the offspring cardiovascular health categories, and showed this association where they clustered together. So if the maternal cardiovascular health was poor in pregnancy, there was a much greater odds of cardiovascular health being poor in the offspring 10 to 14 years later. So reinforcing this idea that the earlier we begin to intervene and manage weight optimally, the better off, not just for the birthing adult, but also for the offspring. The other reason this is really important are the inequities that we see with obesity. Shown here are results from a Kaiser Family Foundation survey that highlights that children who are on Medicaid compared with private insurance have a twice as likely risk of having obesity. And in fact, that translates to a higher burden of chronic conditions like diabetes, hypertension, and hyperlipidemia, beginning even as early as childhood. I just want to touch a little bit on the environmental factors as we're talking about the drivers and upstream potential reasons for obesity. I wanted to show these maps from Chicago. So I'm in Chicago right now in one of the western suburbs, and you can see there's huge variation in the prevalence of obesity, coronary heart disease, and they track and map completely with social vulnerability index. And so we know there are geographic patternings and neighborhood factors that are really related to underlying structural and systemic racism that contribute to these that move beyond an individual level. Specifically, this is a really nice study that looked at this question and asked the question, is the prevalence of obesity different among individuals based on where they live? And they looked at segregation index called the Black Isolation Index or the Hispanic Isolation Index for individuals who identified as Black or Hispanic, and showed that for Black women who lived in an area that was highly segregated or had medium segregation, there was a much higher risk of obesity compared with those who lived in a low segregation area. There was no difference for men. And in fact, there was a reverse, almost protective factor for Hispanic women, which really sets up this question of intersectionality, interpersonal connections, as well as the drivers that lead to neighborhood segregation. So that sets the stage, I think, for really talking a little bit more about this idea that we shouldn't be thinking in isolation about obesity. Obesity has implications downstream on multiple cardiovascular risk factors and cardiovascular disease, but how do we pull these things together? This was really the focus of bringing together the cardiovascular kidney-metabolic health construct by the American Heart Association. We know that there's this close interplay between metabolic risk, chronic kidney disease, and cardiovascular disease. These components are associated with premature mortality, mostly due to increased cardiovascular disease mortality. But with the earlier and earlier onset of these conditions, particularly obesity, the growing burden of obesity in younger generations, it's leading to earlier onset of overt symptomatic cardiovascular disease. We really need to prioritize and focus this. I think the other thing that is just very timely and exciting, as we'll hear about, is that with this better scientific understanding, we also now have multiple new therapies that simultaneously impact metabolic, kidney, and cardiovascular disease outcomes. So these three axes that seem to be coming together. And that led to the development of the presidential advisory and the scientific statement that outlined cardiovascular kidney metabolic health as a health disorder due to connections among heart disease, kidney disease, and obesity that lead together to poor outcomes. This is the overall staging system that highlights the progressive nature of the cardiovascular kidney metabolic syndrome and really highlights the importance of excess and dysfunctional adiposity at the upstream level that contributes to the downstream risk factors, so that we're not really talking about one or the other, but this progression and building upon each. If we look at some of the underlying mechanisms, inflammation seems to stand out, and I know we'll hear a little bit more about fibrosis as well, but this concept that at the center of obesity and its complications, there are shared pathways that may help us better understand how to prevent and manage disease, as well as complications on the kidney, on the heart, and the liver. One thing I just wanted to touch on was because of the emphasis on prevention in cardiovascular disease, part of the CKM Science Advisory Group led to the development of the PREVENT equations, which are a new set of risk prediction equations for cardiovascular disease. While the overarching goal for the risk assessment is to continue to match the type and intensity of interventions with predicted risk, we know that patients with obesity are at higher risk for cardiovascular disease. And so one of the things that we wanted to focus on when we developed these equations was the inclusion of body mass index within the predictors. So shown here is an overview of the cohorts that led to over 3 million individuals being included in the development of these risk models. The predictors, which were fairly similar to older risk prediction models like Framingham and pooled cohort equations, but specifically included body mass index as well as additional predictors of kidney function as well, and social deprivation index and hemoglobin A1C, as well as incorporating heart failure into our outcomes, really trying to highlight the fact that this is a growing problem, largely due to the obesity epidemic. The calculator is available online, and the QR code is listed here, as well as the available link for it. So I just want to conclude with some future directions, controversies, and maybe set the stage for some of the questions for discussion as well. one of the things that continues to be a challenge, and I know this comes up every time we talk about obesity, is that BMI is an inadequate measure. I think we have relied on it in epidemiologic studies because it's easy to ascertain. It's what we do in clinic. But this is an image that shows two individuals that both have the same BMI that would be considered normal. But when you look with body imaging, the body fat percentage is very different, and it has implications for overall health. So I think one of the things that would be helpful to talk about is how do we better have more, how do we more precisely measure what we're trying to do when we say obesity? And I think one thing is reterming or renaming that potentially as dysfunctional adiposity, or thinking more about the function rather than the degree or burden of fat. So traditional anthropometric measures are listed on the left, and thinking about new measurement tools, especially with the availability of imaging tools that can give us a better estimation of composition, distribution, but also blood-based biomarkers with proteomics, I think multi-omic analyses that can really help us understand the biology as well as the function. I think the other thing that always comes up when you talk about epidemiology of obesity and heart disease is the obesity paradox. These were a couple of headlines that I pulled, including a book that was written by Carl Lavie about this question of, is overweight or obesity a disease? Is it really bad? Are there outcomes that are better with people who have overweight or obesity? And I think this is something that fundamentally requires a more nuanced perspective than just a clear one-way answer. For most risk factors like blood pressure and cholesterol, this curve is completely linear. The lower you go, the lower your risk. It's a little bit different with weight, because we know there's a lot of complicating factors like frailty, sarcopenia, chronic disease that lead to weight loss that are not healthy changes in weight. So this understanding that the paradox doesn't mean that weight loss isn't helpful or beneficial to prevent heart disease, but we need to understand it in the context of the person. And I think as we learn about more and more experimental evidence that suggests that lowering body weight is effective at reducing risk, I think that is the strongest causal argument for promoting weight loss, but understanding that it needs to be done in a healthy way. The last thing I'll share are these projections that I think really lead us to why we're here today and why this is such a critical problem, and it's timely and urgent. We know that projections for obesity continue to show striking numbers. This is an analysis that was published pre-COVID that highlighted with maps for the first column overall obesity getting more and more red and creating a new category of purple, and for severe obesity getting more and more yellow, with an estimate of over 50% having obesity, with significant racial and ethnic and socioeconomic disparities, whereby individuals who are non-Hispanic Black would have the largest number would be in a category with obesity by 2030. The American Heart Association recently conducted projections for going even past 2030 to 2050, and suggests that 61% of US adults, or 180 million people, will have obesity by 2050. 27%, or 80 million, will have diabetes. And together, this will really balloon healthcare spending up to 1.8 trillion. I think the other thing that we can't emphasize enough is that we may actually be losing the war on obesity if we wait until adulthood to manage this. This was a really nice analysis that was done to look at what is the risk of obesity by the age of 35 among children today. And they estimated that 57% of children today will have obesity by age 35. And for those who already have obesity, they have severe obesity by the age of 19, they only have a 6% chance that they will no longer have obesity at age 35. So the fact that even intervening at that point may be too late, which is what's shown in this first curve here as we see the progression of risk for obesity. And in the second panel, for a child that's 2, they're hitting their peak risk. About half of them have developed obesity by their teenage years before they become adults. So I'm going to conclude with 4 key takeaways. Obesity is a prevalent, costly, and chronic disease, and has significant disparities that are due to individual, interpersonal, and structural drivers, including racism. Obesity is associated with cardiovascular disease across the life course, particularly heart failure and adverse pregnancy outcomes. And this has significant implications for intergenerational transmission of risk and disparities. The novel AHA construct of cardiovascular kidney metabolic syndrome and the new PREVENT calculator really recognize the pathophysiological interrelatedness of obesity, diabetes, CKD, and CVD, and help us perhaps inform a research agenda as well as a clinical agenda on how we manage and optimize outcomes. Some of the future directions, and really interested in the discussion on this, I think, are to think about how we assess adiposity, how we understand the mechanisms of dysfunctional adiposity, and critically think about implementation and policy that begin earlier to intercept this growing public health crisis and mitigate disparities. Thank you so much for your time and attention, and I'm happy to take questions.
Great. Thank you so much for a really interesting and comprehensive talk. We have several questions in the chat, and I'm going to start out. I'm going to ask Dr. Borlaug if he wants to unmute and ask his question directly.
I would be happy to. First, I want to say that was a really brilliant talk, Sadiya. Thank you so much. That was, I mean, I can't believe how much you covered and so clearly. So thank you. One question I think that's really important is disentangling what's normal by race, ethnicity, where they're from. And you showed that nice data with different people from different parts of Asia or different, you know, they're not all the same. And so how are we going to establish what's normal, and how do we balance like being more informative and granular with being practical for making these definitions? What are your thoughts on that?
Thanks, Barry. You had to start with a question that was so challenging that we could spend the whole hour talking just about that. I think this is a really important question in terms of understanding where did the body mass index cutoffs even come from, right? And so I think if we think about the genesis of those cut points, they were created to understand the risk for disease. And so that 25 and 30 cutoff is really thinking about what is the increased risk for diabetes or cardiovascular disease on a population. And we know there are differences where certain groups, particularly, for example, South Asians, have a much higher risk of diabetes. And I think the data from the Masala study show us really nicely that when you compare to adults in the MESA study, the BMI cut point of 19 for South Asians is about the same as that of 24 for white Americans for risk of diabetes. And so this sets up this question of, well, what drives that? Race is a social construct. And so I don't think that we want to say that we want to consider race-specific thresholds for what we would do for treatment, but perhaps there's ways to understand risk if we can untangle what are the mechanisms that lead to that. And so better understanding the biology of why those differences exist is, I think, the first step. So I'm not giving you an answer because I don't think we know why. And so until we do, I think it's really hard to say that we should have different cut points, different thresholds, or try to do things that oversimplify something that is really complicated.
Great, thank you so much. And Eric Sharoma, I know had a question. Eric, do you want to unmute yourself and ask?
I'm actually going to let the more interesting questions after me come
All
up,
right.
but I'll save mine for the panel for later.
All right, that's fine. Here is another. Someone mentions the body roundness index, or BRI, which I know has gotten a lot of attention lately, and just makes a comment that perhaps we should be looking at that as a risk factor. And I guess some of these big observational studies would give the opportunity where you have health outcomes to look at the different types of calculations for adiposity and see what tracks best with the outcomes we're interested in. Do you have any comments about that?
I think it's a really great point, and we need more of this. I think we have to move away from just accepting that BMI is the best way to do this, and if we are able to look and evaluate other tools. The body roundness index is a really nice one. I think if we think more broadly, are there biomarkers? Are there other imaging tests? Are there ways that we can integrate this information? I think someone mentioned wearables. Are there ways that we can actually start to use? There's so much data, and we have the capacity today to collect a lot of data, but we're not maximizing our ability to use it yet, I think.
Thank you. Another question from Liz Picas is a wonderful talk, Dr. Khan. The prevent calculator includes zip code. for estimating SDI. Can you please please elaborate of the impact of this variable on risk calculation?
Yeah, thanks, Liz, for that question. I think as you saw in the maps, we know that neighborhood matters in terms of cardiovascular disease risk and risk factors like obesity. And so one of the things that we wanted to incorporate into the risk prediction tool was a measure of place-based social determinants of health with the social deprivation index. So that helps to a little bit tailor what an individual's risk estimate is based on where they live. Of course, it's not perfect when someone moves or if someone lives in an area, but their personal circumstances may be different from others in their area. But I think it's a crude and at least a first starting point.
Thank you. I think we'll have time for one or two more questions. This one notes that the state with the highest rate of obesity is West Virginia, in which more than 97% of the population is white or Caucasian. How can this paradox be explained?
Yeah, I guess it's an interesting use of the word paradox. I think we've known for a long time that there are factors like rurality and socioeconomic status that contribute significantly to obesity as well. And I think West Virginia is a great example of unfortunately having a very, very high burden of poverty and rural areas. And it's largely, as you mentioned, white, and I think has been an area that has been underappreciated, but hopefully with more and more awareness of different types of disparities, particularly related to income, rurality that move beyond social, just focusing just on race and ethnicity, will be able to more equitably reach individuals who are affected by this.
Well, great. Well, thank you so much, Dr. Khan. That was a wonderful talk. And I think at this point, I know that Dr. Gibbons is now here with us in the room, and I'm going to ask Dr. Lori Donzi from NHLBI to introduce Dr. Gibbons.
Okay, thank you, Sue. Hi, everyone. Welcome again. And thanks to Dr. Khan for that really interesting talk. I'm a program officer at NHLBI, and I'd like to introduce our director, Dr. Gary Gibbons, the director of the National Heart, Lung, and Blood Institute, and he is also one of the co-chairs of the NIH Obesity Research Task Force. So Dr. Gibbons, turning it over to you. Let's see, so just be sure to unmute and turn on your camera. Let's see, well. Oh, here he comes. Dr.
Hello?
Gibbons, oh yeah.
Okay, I'm sorry, I've been having connectivity problems with Zoom. I'll make this very brief of just greetings and appreciate the opportunity for this convening of this excellent seminar series here and the various talks aligning with cardiovascular disease and obesity. We've already had a terrific talk. I won't get in the way of moving on in the agenda given the technical difficulties. But again, we appreciate the speaker's participation in addressing this very important issue. And with that, I'll turn it back so we can keep the momentum of these terrific talks. Thanks so much.
Thank you, Dr. Gibbons. It's my pleasure to introduce our next speaker, Dr. Philipp Scherer. Dr. Philipp Scherer is the Gifford O. Touchstone Jr. and Randolph G. Touchstone Distinguished Chair in Diabetes and the Director of the Touchstone Diabetes Center at the University of Texas Southwestern Medical School or Medical Center in Dallas, Texas. Current efforts in his laboratory are focused on the identification and physiological characterization of novel proteins that serve as potential links between the adipocyte, liver, and pancreatic beta cell with the processes of whole body energy homeostasis, inflammation, cancer, and cardiovascular disease. His research team aims to identify novel targets for pharmacological intervention and to further define the role of adipose tissue as an endocrine organ. Dr. Scherer has received multiple awards and honors, including the Banting Medal for Scientific Achievement from the American Diabetes Association, the European Association for the Study of Diabetes Novo Nordisk Foundation Diabetes Prize for Excellence, and the 2018 Monpai Suzuki International Prize for Diabetes Research. Dr. Scherer's talk today is entitled Fibrosis, a Common Pathway for the Cardiovascular Kidney-Metabolic Disease. Please help me welcome Dr. Scherer.
Eric, thank you so much for the kind introduction. It's a pleasure to be part of this illustrious setup of speakers. We certainly had a wonderful introduction now from the epidemiological side by Dr. Kahn, and I'm going to try to take this a little bit more down to the molecular level in terms of the connection between the two. My disclosures, very briefly indicated here. So a little while ago, a couple of colleagues of mine, Sam Klein at WashU and others, have been musing about what is the exact connection between obesity and diabetes specifically. So this is an apparently trivial question, but actually an incredibly difficult one to answer. And we certainly mused about many of the possible connections, but we fell short of actually providing a direct answer to that question. And the same question could be asked, why does obesity cause cardiovascular disease? And again, there's a lot of thought that goes into that in terms of what the molecular underpinnings are between these connections. And it becomes clear that there is much that needs to be learned. It is clear also that we are undergoing a revolution right now, and Dr. Kahn already hinted at it. We all are aware of the fact that the incretin-based therapies really offer for the very first time a major impact in terms of reducing the obesity burden on various disease areas. Obviously, with a lot of problems that come with it, there are some side effects. There are, more importantly, questions related to access to these interventions. And we all hope that over time, this is somewhat going to evolve as multiple companies enter the arena and offer various versions of this. But they can come in different flavors, as we know, single agent sort of GLP-1 receptor agonists, dual agonists that include the GIP receptors, and most recently, perhaps in the making, the triple agonists that include, for instance, a glucagon receptor component to them as well. So you can see that at least in the context of the clinical studies, a 25% weight reduction is well within reach. And this is obviously an area that moves incredibly fast, and it became quite rapidly clear that this is more than just about weight loss per se, but this entire, as we heard about the AHA definition of the cardiorenal syndrome, basically is affected by seeing clear-cut dramatic improvements in chronic kidney disease here. We have, of course, the liver component in there as well. With 25% weight loss, you lose a lot of fat in your livers as well, basically. And of course, last but not least, in the context of the topic today, we have a major impact on cardiovascular disease, in particular, the well-established connection between obesity and heart failure. HFpEF is something that sees major leaps forward in terms of patient outcome after being on these incretin drugs. Incredibly fast moving. I think today, for instance, marks the end of the European Association for Diabetes Research meeting in Madrid. And again, whenever you have these large gatherings, there are many reports that come out, and things move so rapidly that it is almost impossible to really stay on top of it if you haven't read this week's issue of either the New England Journal or the Lancet. We've tried to sort of summarize the field as good as we could at the beginning of July in this overall review in Cell that takes sort of a large sort of scope at both the clinical and the preclinical data. The review came out at the end of July, but by the time it came out 4 weeks later, it was already partially outdated. So it is a really dramatic time that we are living in, and these clinical improvements that we see across the board of the cardiorenal sort of syndrome side, that includes also diabetes, of course, are probably as significant as they've been in many, many years. And one of the sort of bottom lines that we walk away with is that most of these changes, not all of them, but most of these positive changes on secondary outcomes rely critically on weight loss per se. And that really sort of changes our outlook a little bit in terms of what the critical cell type is that we should be focusing on. Weight loss means there is an impact on our fat cells. Not to be excessively silly here, but basically it does recalibrate our views on what we should consider a healthy fat cell versus an angry fat cell here on the left side that exerts a lot of negative impact on many different tissues in terms of this tissue crosstalk. So it really is a matter of learning better more about how we define a healthy adipose tissue, a healthy adipocyte, and how that can exert basically all these positive effects on the various tissues that we are looking at here. The other question that we could raise, given that the dramatic changes that we see in terms of patient outcome in all these different areas, are we done? Is this as good as it gets? Do we have any additional possibilities to develop strategies that outperform basically this, it's almost magical impact that these weight loss drugs have? And I think that is an absolutely valid question, and certainly affects the way we think sort of in the trenches in terms of target discovery of new molecules that might actually not replace the incretin action, but maybe add on to the actions of the incretins. We are not completely done, because I like to refer to what we are left with after we've lost 25% of our body weight as residual disease. This is obviously a term that I like to sort of borrow from the LDL cholesterol world from my colleagues down the hall, Brown and Goldstein, appreciating that even though you may be on statins and you significantly lower your LDL cholesterol, there still remains an increased risk for cardiovascular disease. And that's what was generally and historically referred to as the residual disease. We have residual disease post-weight loss as well, and we see that particularly, I guess, in the liver most prominently, but it's also applying to all the other target organs, including the fat itself, the adipose tissue, the kidney, as well as the heart. And that is really related to the fibrotic component. And that's of course widely discussed basically in the context of MASH and MAFLD interventions. And you see here a series of additional interventions that have been worked on and continue to be worked on. It turns out that the lowering of liver lipids, the steatotic component, are relatively low-hanging fruits, and most interventions, including just a little bit of weight loss, will actually drain the liver quite effectively of the lipid component. But what remains is, of course, the fibrosis. And when you read most of the clinical study outcomes in the various areas, including the incretins, you will actually read very clearly that there is a dramatic impact on liver, on hepatic lipid content and the steatosis, with no further worsening of the fibrosis. So that's sort of in the small print, no further worsening. So that really indicates that fibrosis remains a big issue. And that fibrotic component, of course, in the liver is local, but it also is in response to a dysfunction at the level of adipose tissue. And particularly in the context of the liver, I think the relative health of the adipose tissue and the fibrotic state of the adipose tissue is very clearly and very tightly coupled between these two tissues. So just like the liver, just like the kidney and the heart, dysfunctional adipose tissue is fibrotic adipose tissue, and we've appreciated that for a number of years. And this increased fibrosis in adipose tissue, which is mostly the result of an initial hypoxia during the expansion, but then there's an inflammatory component in there as well, is really driven basically by leading these extracellular matrix constituents sort of leading to a freezing of that adipose tissue flexibility. And as a result, it has a very negative impact, of course, not only on the local inflammatory level, but also the local insulin sensitivity. So our sort of approach is generally sort of based on the fact that the fibroinflammatory milieu is a key contributor to disease, and that the adipocyte is one of the key drivers for this systemic sort of fibroinflammatory state in this context. So it is highly worthwhile, in our view, to look for connections between this fibroinflammatory state in the adipocyte and the state that other additional tissues are in this context. So looking, of course, specifically at some of the factors that fat cells release in the dysfunctional state, and then focusing on how these factors change in the context of the massive weight loss that we now see with the help of these incretin drugs, we have a number of candidates that I would like to briefly mention, and one of which is kind of an obvious one, leptin. Leptin obviously has been around for many years by now. It's actually the 30th anniversary of leptin, yet sort of a pharmacological use of leptin has been very, very limited, because the vast majority of us, 95, 98%, we are all leptin resistant. So the original idea of leptin serving as sort of the link between obesity and food intake, as well as energy expenditure, that link is mostly dysfunctional in most of us. We proposed a bit of a heretic view of this a couple of years ago, which I think by now is actually pretty widely accepted, that part of an approach to overcome this leptin resistance would simply be to reduce the peripheral leptin levels, which is, of course, what happens when you lose weight. But we have additional means in the form of neutralizing antibodies by which we can reduce leptin in the periphery and actually achieve a leptin sensitization centrally and allow leptin to exert its function again in the hypothalamus and in other critical regions, but also in the periphery. Actually, leptin as a close relative to IL-6, interleukin-6, leptin in the periphery exerts a potent fibrotic and inflammatory action as well. And any change that we can basically bring about in the form of leptin lowering is actually beneficial per se, almost independent of the weight loss on the side, and any increase in leptin is actually doing the opposite. So the historic view of leptin has been that it's a passenger to obesity. You're lean, you have low leptin, you're obese, you have high leptin. We would basically turn this a little bit upside down and say, no, it's not a passenger, it's an actual driver of obesity. And you can see this and sort of demonstrate this concept in a couple of different settings. So if we go back to the original incretins that mediate a lot of weight loss in this particular case, you can see that, you treat mice with a liraglutide, they lose weight. It turns out that this, of course, leads to a lowering in leptin. We can assist the incretins by lowering the leptins even further by sprinkling in a neutralizing leptin antibody. So with equal or less GLP-1 receptor agonist in the system, we can achieve more weight loss. And in a preclinical system, you can, of course, play all these genetic games, and we can actually show that even though the mechanism of action of the incretins leading to weight loss is sort of distinct and separate out there, they have to lower the leptin levels at the end of the day. So if you genetically prevent that drop in the leptin levels, the incretins lose much of the bang for the buck. So the lowering of leptin is sort of the final readout at the end of the road that has to occur in this particular context. The opposite holds true as well. So when you examine what happens when someone goes on an antipsychotic drug regimen, obviously wonderful drugs that save lives, But one of the major side effects of antipsychotics is a massive weight gain. And when you do this in a more temporally refined way, and you analyze that, you'll see that leptin levels shoot up immediately after going on an antipsychotic. And it's really the increase in leptin that drives the insulin resistance and the increased obesity. And when you neutralize the leptin in this context, you can actually avoid many of the side effects that these antipsychotics exert. And interestingly enough, not only is an antipsychotic mouse model basically an interesting model for weight gain overall, it turns out, of course, with the metabolic dysfunction that these mice experience, they also experience problems both at the level of their kidneys and as well at the level of their livers. And the livers become steatotic and fibrotic. And you can see here, for instance, when we treat these mice with neutralizing leptin antibodies and examine their livers, we can actually see that the neutralization of the leptin antibodies is associated with a dramatic reduction in the hepatic fibrosis. So there is definitely a potent connection here with the fibrotic readout in the periphery as well. So leptin, we all knew about leptin, and this has been around for a while, but I think I want to introduce a very, very important newer factor in this context that offers actually really great potential now, particularly as it relates to cardiovascular disease. Endotrophin is a molecule that we have defined about a dozen years ago and have quietly been working on it, but there have been maybe over the last 2 years, fairly dramatic events, for not just from us, but also from other groups that demonstrated how powerful a factor this endotrophin is. It's not a separate gene. It's a cleavage product of a collagen, specifically collagen 6 alpha 3. You see here that C5 domain is actually what people call endotrophin. Other people call it pro-C6. You see that in many of the large clinical studies where it's still, on occasion referred to as pro-C6. So it's not its own gene. And it originates from this collagen 6 fibrillar collagen, which is basically the glue that holds our fat tissue together. And that becomes dramatically upregulated in the context of dysfunctional fat, fibrotic fat. And then in many other tissues, as you'll see, the liver, the heart, the kidney, once you have a fibrotic lesion sort of emerging, they also experience a massive upregulation of local collagen 6 production and the associated endotrophin. This is a potently pro-fibrotic factor that acts within the tissue itself, but some of it escapes into circulation, and you can actually measure it with an ELISA or by other means, and actually study the correlations of endotrophin in circulation with various disease phenomena. You can see here a fibrotic human breast tissue here, as stained for endotrophin. You can see that the endotrophin levels are locally present at much, much higher level. That, of course, also in this particular case predisposes the mammary gland for an increased cancer incidence as well. It is a factor that is closely correlated. In fact, we know it's a driver of insulin sensitivity in adipose tissue. We know that from preclinical models. Sam Klein's data here at WashU correlates the insulin sensitivity with the endotrophin levels by looking at his cohort of metabolically healthy obese versus metabolically unhealthy obese. So these people are adjusted for BMI, but however, the metabolically unhealthy obese have much higher endotrophin levels in circulation, and that correlates very well with the differential insulin sensitivity between these two groups. So it is a driver for insulin resistance in this context. And much of what I've shown you for leptin in terms of its anti-fibrotic action, you can also show for endotrophin. So for instance, a fibrotic liver, in this particular case, it's an ER stress liver, the MUP mouse, you can effectively lower the fibrosis level with neutralizing endotrophin antibodies that take some of that nasty endotrophin out of circulation and improve the local fibrotic and inflammatory state in the liver as well. And with all of these sort of preclinical clinical correlations, we have an associated sort of preclinical gain and loss of function model. So clinically, again, we see that the endotrophin levels correlate very well with MASH and MAFLD as well. So that's an excellent circulating marker. And just to mention the complete cardiorenal sort of phenomenon, you can actually see this in the kidney as well. Endotrophin in the kidney is expressed at very high levels. This is a complicated slide, but suffice it to say, when you neutralize leptin in a model of kidney dysfunction, in which we actually provide an insult to the podocytes, sort of our own diabetic renal disease model, we can actually see a dramatic improvement in the fibrosis, in the inflammation. And when you neutralize the fibrosis in the context of chronic kidney disease, the functional reconstitution of the kidney follows suit very closely. And we can see here in the histology very nicely how the kidney recovers in this context and functionally is reconstituted completely. And again, many clinical exciting correlations at the level of the kidney as well, whether that's chronic kidney disease, whether that's acute kidney injury. Published studies now from a number of different groups, and we see it in our own cohorts here on campus very well as well. End-stage renal disease is associated with a dramatic increase in circulating endotrophin. So we believe it is a marker, but it is also an interventional target. Now, the actual meat of the talk here is, of course, a relationship between endotrophin and the heart. And this was really stimulated by this big study here from BMS, where colleagues from UPenn were driving much of that. This was an interventional study for HFpEF in the context of SGLT2 inhibition. And what they found here is basically that the measurements of endotrophin were actually quite revolutionary in the sense that compared to the conventional sort of HFpEF markers that are being used out there, whether that's the MAGIC score or whether that's pro-BNP, that the endotrophin as levels outperform every single other marker that's out there dramatically. Now, whether that's heart failure per se, overall death, or the primary endpoint. So it's quite significant. And you can put these patients into tertiles where you have high, medium, and low endotrophin levels. And it is clear that each of these readouts is quite significantly driven by and predicted by the different endotrophin levels, with high endotrophin being a relative risk factor for the whole thing. Preclinical FPEF models, just one quick thing. Yes, we have basically supportive data in the preclinical setting together here with Joe Hill's group on campus that shows that the intervention with neutralizing endotrophin antibody in an LNAME sort of high-fat diet model of heart failure HFpEF, we do see very significant improvements in the readouts as well. Arguing again, this is not just a marker, but an interventional target. And you can basically see that in many other settings where you have cardiac fibrosis kicking in, whether that's an ischemia reperfusion setting, where you also see a lot higher levels of endotrophin sort of popping up within the local heart tissue as well. So it goes beyond that. There is certainly a lot of GWAS and proteomics, plasma proteomics studies, data out there as well that highlights that there must be a direct connection between endotrophin levels and cardiovascular disease, specifically here, for instance, in coronary artery disease. Work that we've done in collaboration with Nate Steitzel at WashU, really implicates a couple of factors as well in a completely unbiased way. They set out to take advantage of a number of large cohort studies with the associated plasma proteomics as well. And what was rewarding, of course, in this context, that some of the major drivers for CAD that popped up are known players in the field, such as PCSK9. You can see that they're on top. But at the same time, you can also see that the odds ratios are actually most dramatic for endotrophin. And there are two different aptamers here for collagen 6. The one that really correlates well is the one that goes with endotrophin, and the one that doesn't show too much of a correlation will be the parent molecule, collagen 6, the fibrillar component. So again, we can infer basically causality almost in light of these very strong sort of risk factors. The source in the heart in this context of endotrophin is not entirely clear yet. It is probably also coming at least partially from the cardiomyocytes, but let's not forget about the fact that we have a lot of pericardial, epicardial adipose tissue here as well in the immediate neighborhood, and that, of course, is also constituting an important source for that. Now, many epidemiological studies are popping up at a high and rapid rate here. A lot of it driven by a assay company in Copenhagen, Nordic Biosciences. They really delivered the readouts for all of the big pharma companies in terms of the pro-fibrotic components. And it is clear from many of these studies that integrate a lot of data that, again, the odds ratios, for instance, for cardiovascular disease are dramatically higher if and when the endotrophin levels are elevated in an individual, basically. So we've mused about this again. Also, we've tried to summarize and stay on top of the rapidly moving field here by putting out some of the sort of ideas about how exactly endotrophin could exert these effects. We understand that a little bit at the level of the cellular signaling. For all practical purposes, you could look at endotrophin as a TGF-beta-like molecule. It's distinct from it. Neutralizing TGF-beta has not been a good option historically because of many side effects. Neutralizing endotrophin in this context is actually without any sort of side effects that we have observed. In fact, we have generated recently mice that lack specifically just the endotrophin moiety, and these mice are actually just fine. They're doing great. Until you challenge them either with a heart stimulus, a kidney, or a liver stimulus, and then you actually see how these mice perform much better in the absence of endotrophin. We have yet to find an actual function for endotrophin that's beneficial. That's actually the same thing for PCSK9. We don't really know why we have PCSK9. It's a troublemaker out there, and the same seems to be true so far for endotrophin as well. And obviously, with that rapidly evolving literature out there, it is a lot of exciting clinical correlational data, and increasingly also at the preclinical level, we can see that endotrophin is really morphing into a very, very powerful biomarker for fibroinflammatory disease that really predicts outcome in many different settings, including cancer, which is also a fibroinflammatory disease. But the main focus is really on the fibrotic actions of endotrophin, and it has significant potential that we can neutralize the endotrophin and take it out of the equation. Now, in my remaining sort of minute or so, I do want to also extend sort of that cover of fat-derived factors that will be characteristic of either an angry dysfunctional fat that most of us carry around, or the improved happy fat here. There is a lot of factors, adipokines and others that fat cells sort of release, and that then in turn have a direct impact, for instance, on the heart. Related to that is certainly an emerging literature that talks a lot about the lipotoxicity that comes with excess lipids in the system. And the major drivers for those are the ceramides, and the ceramides locally are again governed predominantly by events taking place at the level of the adipocyte. And one of the key anti-lipotoxic factors that is out there and that lowers the ceramide levels effectively locally as well as systemically is our old friend adiponectin. Again, that one, of course, is expressed at much higher levels in healthy lean adipocytes and is dramatically suppressed in obese, big, and inflamed adipocytes. As such, a direct downstream reflection of the health of adipose tissue and the associated effects that lipotoxicity exerts. So ceramides downstream of the adiponectin receptors, and then not having time to spend too much about FGF21, but FGF21 is another factor that basically is upstream of adiponectin. Higher FGF21 results in elevated adiponectin, lower ceramides, and lower sphingolipid levels overall. So to remind you, these were the factors, the leptin, the endotrophin. I hope you're going to get to see a lot more about endotrophin in the near future. This is a marker which is up and coming, and that turns out to be extremely useful. Want to thank my colleagues in my lab, on campus and off campus in many different areas, which have contributed to this in major way. And I want to thank you for your attention in this context.
Well, thank you so much, Dr. Scherer. I think that was really a compelling talk. And I know for me, it's really changed the way I'm looking at the commonalities underlying many of these obesity-related complications. And we do have some questions in the chat, so I'll start right out with them. Dr. Borlaug, do you want to unmute yourself and ask your question?
Yeah, that was so wonderful. Thank you. And such an impressive body of work. And I have too many questions. I don't want to take the whole conversation.
Pick one.
I was thinking, and I guess you could say it with leptin, you could say it with pro-inflammatory cytokines like IL-6. You could say it with endotrophin. If you could, I guess one very speculative question, you keep the obesity the same, but you antagonize these, how much benefit would you see? And then the converse question is, if all of these are related fundamentally to excess body fat, does it even really matter? Do we just need to focus on the body fat now that we have these really powerful drugs that you started off the talk discussing?
Yeah, those are good points. And again, my starting point was because we, these incretins lead to a massive drop, predominantly, not exclusively, but predominantly at the level of fat mass that, maybe I think what caught all of us by surprise is the fact how powerful an impact just the weight loss itself had. I mean, for decades, the ADA, we've put these guidelines out where say you have to lose as little as a few % of your body weight and your insulin sensitivity goes up. Absolutely. But this only scratched the surface in terms of now what we see at the level of HFpEF, chronic kidney disease, and the liver. So the focus on weight loss has to be what we walk away with most of these. Now, yes, you can interfere at the level of these factors only without necessarily affecting the obesity per se. And the model for that is the metabolically healthy obesity versus the metabolically unhealthy obesity. And the differences are exactly at the level of these factors. So a metabolically healthy, higher adiponectin, disproportionately lower leptin, and of course, very clearly lower endotrophin levels. So this is basically, even in the absence of intervening with the obesity, playing with these factors is a key segue into the whole world of dysfunction.
Thank you.
So we have time for about 2 more questions. So I'm going to pick a couple out here. One asks, do improvements in metabolic flexibility play a role in explaining the benefits of GLP-1 GIP receptor agonists on cardiometabolic outcomes, or would you see improvements in metabolic flexibility as a mere result of weight loss? What are the weight loss independent effects of GLP GIP on metabolic flexibility?
Very deep question, and probably would take a long time to really answer that. The incretins have GLP-1 has a direct effect on the beta cell. Obviously, we improve our glucose-stimulated insulin responses as well. Nevertheless, I think what we are looking at in terms of improved metabolic flexibility is really, again, driven by the adipose tissue in terms of its ability to adapt to feeding versus fasting. I love the term metabolic flexibility. Other people simply argue it's basically insulin sensitivity. In either case, that improves dramatically at the level of adipose tissue, and I would call that out as one of the things that's a function of weight loss, first and foremost, driven by the healthy adipose tissue that you stick with at the end of 20% body weight loss.
Thank you. And Dr. Khan, do you want to ask your question? Do you want to unmute yourself?
Yeah, thank you, Dr. Scherer. That was really incredible and helpful to see some of that evolution of understanding of the biology. One of the things clinically that we've noticed with the use of these incretin agonists is that people stop them a lot. And when they stop them, the regain tends to be not necessarily going back to baseline, but I wonder if the mechanisms or the factors that we see when people successfully lose weight are the same ones that are returning, or is there something different, or do we know?
Well, again, the bounce back is something which is really opening up an entirely new field of physiology in terms of the yo-yo. It used to be called yo-yo dieting, but now it's basically you on the drug, off the drug, on the drug. And every time this happens, you, for all practical purposes, either bounce back to the original weight. Some people manage to stay a little bit below that. And that's still, you know, we should not forget the fact that many people stay 5 to 8% below the starting weight. Nevertheless, the regain is not something which is particularly healthy if it's done repeatedly, because people argue every time you regain that weight, it is preferentially fat mass and less lean mass. Again, some people would disagree with that. But the fact is, when you do this a couple of times, the fibrosis at the level of your adipose tissue is actually increased. That's beyond any dispute. And that increased fibrosis is probably a burden that people have to carry along with that frequent on-off cycling on these drugs. Hopefully, that will level out in the next couple of years. The cycling, is it because of availability of the drugs? Is it because of the side effects? Is it simply that people, don't care enough to stay on there? We'll see as the availability improves. I think a lot of these things will hopefully level out, and the prices will hopefully also come down along with that.
Great, thank you so much. We have other really good questions in the chat, and what I'd encourage people is we are going to have the panel discussion today at 2. So please hold on to your questions, and we can probably get to some more of those at that time. I'm going to turn it over to Dr. Shiroma now to introduce our next speaker.
Great talk so far. It's been a really informative morning so far for me. I'd like to introduce Dr. Alvaro Alonso as our next speaker. Dr. Alvaro Alonso is a professor on the Stephen D. Clements Jr. Chair in Cardiovascular Disease Prevention within the Department of Epidemiology at the Rollins School of Public Health, Emory University. Before joining Emory University, Dr. Alonso served as faculty at the University of Minnesota. His research primarily focuses on the epidemiology of cardiac arrhythmias, particularly atrial fibrillation. Additionally, Dr. Alonso is engaged in studies that explore the connections between cardiovascular health and neurodegenerative diseases. Dr. Alonso's talk this morning is entitled Obesity and Cardiac Arrhythmias, Opportunity for Prevention. Thank you for joining us this morning, Dr. Alonso.
Thank you, Dr. Shiroma. Thank you to the organizer for inviting me to be here today. Hopefully everyone can see my slides. So the title of my presentation is Obesity and Cardiac Arrhythmias, Opportunities for Prevention. Just to get us started, I have funding from NIH and American Heart Association, and I do not have any other relevant disclosures. This is what I would like to cover today during my presentation. I'm a cardiovascular epidemiologist. A lot of the conversation and my point of view when talking about this has to do more with population health science and the impact of obesity on arrhythmias at the population level, more than focusing on the specific mechanisms, though we will mention some of that as we move forward. So I will start talking a little about what we know about the links between obesity and atrial fibrillation as the most common clinical arrhythmia. Then we'll cover links between obesity and sudden cardiac arrest as a major manifestation of ventricular arrhythmias, and we'll end the presentation discussing some aspects about weight loss and the risk of arrhythmia as we try to refocus on prevention of arrhythmias in people with obesity. Let's start with obesity and atrial fibrillation. To begin, I will just to go quickly over the concept of atrial fibrillation. What is atrial fibrillation for those of you who may not be familiar with this disease? So atrial fibrillation, also called AF or AFib, is a cardiac arrhythmia, disorder of the heart rhythm, which is characterized by the presence of disorganized, rapid, and irregular atrial activation. That would be the upper chambers of the heart. They don't function normally, they don't have the proper electrical functioning, and that results in irregular ventricular response, which could be seen easily in the electrocardiogram with these irregular QRS complexes, or if you take the pulse of someone with AFib, they're going to have an irregular pulse, right? And the issue with AFib is that patients who have AFib, some of them may be asymptomatic, some of them may experience symptoms like fatigue, chest pain, shortness of breath, fatigue. But more importantly, AFib is also linked with an increased risk of a stroke, heart failure, dementia, and also increased risk of mortality, which makes it an important clinical problem. In addition to that, atrial fibrillation is quite prevalent in the population. Recent estimates suggest that more than 7 million Americans will have atrial fibrillation by 2050. And because atrial fibrillation is associated with aging, the prevalence these numbers will go up as the population in the US ages. There are around 4 to 5% of Americans between 65 and 79 years of age that will have AFib, and this prevalence goes to over 8% among those 80 and older. Because of the high burden in the population and the relevance of atrial fibrillation as a risk factor for other cardiovascular diseases like stroke and heart failure, there has been a lot of interest in trying to understand what causes atrial fibrillation, what are the determinants of atrial fibrillation, and then what can we do maybe to prevent this disease from occurring. And the same as we have seen for many other cardiovascular diseases, and Dr. Khan earlier talked about that, obesity has been considered as a risk factor, has been considered as a potential risk factor for atrial fibrillation. And over the last 20, 30 years, there have been multiple epidemiologic studies that have shown how individuals who are obese are at an increased risk of atrial fibrillation. So starting with this paper, seminal paper from the Framingham Heart Study published now 20 years ago, showing how individuals who are obese or overweight had a higher risk of atrial fibrillation compared to those who had a normal BMI. There have been multiple other studies conducted in numerous settings here in the US and in many other countries that have consistently established obesity as one of the most important risk factors for the development of AF. One limitation of these epidemiologic studies, obviously, is that we are talking about associations. We cannot prove directly causality just with the information coming from these studies. So there is the question whether it's obesity or other factors that may be potentially associated with obesity risk that explain these associations. And one way of addressing that has been doing what we call Mendelian randomization studies. These studies basically try to look at genetic variants associated with a risk factor, in this case, obesity, and try to see if those genetic variants are also associated with the risk of the disease that we are interested in studying, in this case, atrial fibrillation. So if we find that gene variants that are associated with obesity and only with obesity also increase the risk of atrial fibrillation, because the gene variants are going to be independent of lifestyles and socioeconomic factors and other factors, we can determine that particular risk factor is really causally associated with the outcome, right? And that's what many studies have been able to find. So here in your screen, what you have is a result from a meta-analysis, a combination from multiple studies that looked at genetic variants associated with increased BMI and the risk of atrial fibrillation. To the left side, you have a meta-analysis of studies looking at the presence of risk alleles in the FTO gene, which is one of the strongest predictors of BMI, and presence of one allele of risk allele for FTO was associated with a 7% increased risk of atrial fibrillation. And then to the right, you have the association between a gene score of BMI, mainly a combination of multiple genes associated with higher BMI, and what was their association? Its association with atrial fibrillation. In this case, also one standard deviation in the gene score was associated with a 6% risk in atrial fibrillation, suggesting that very likely obesity is a causal risk factor for the development of atrial fibrillation. In addition to trying to understand the link between obesity and the new onset of atrial fibrillation, there has been also interest in figuring out whether obesity can be associated with outcomes in individuals who already have atrial fibrillation. And for example, one aspect that has been extensively studied is the link between obesity and outcomes in patients who undergo catheter ablation for atrial fibrillation. This is a common procedure that is used for symptomatic patients with paroxysmal atrial fibrillation and other types of atrial fibrillation. And one limitation of this procedure is that it has a high percentage of recurrence of the disease after the procedure. And what has been seen here, and you have the results again of a meta-analysis looking at multiple studies examining this association, is that a higher BMI is associated with a higher probability of recurrence of the arrhythmia after the procedure, with a 15% increase per 5 units increase in BMI. And also you can see here to the right, the dose response meta-analysis looking at BMI levels and the risk ratio of recurrence, and how you can see that there is a clear linear association between atrial fibrillation, between obesity, higher levels of BMI, and atrial fibrillation. Later on, we'll talk about the potential impact that weight loss can have on this and what has been done at this respect. This is just to give you an overview of how obesity may be associated with atrial fibrillation risk and with outcomes in patients with atrial fibrillation. So briefly, let me just mention some of the potential mechanisms that can explain this association, though we have heard some aspects related to the link between the underlying mechanisms linking obesity and cardiovascular disease, and we'll hear more later today. But briefly, we can think about obesity leading to an increased risk of atrial fibrillation through systemic effects and local effects. In terms of the systemic effects, we can think about obesity leading to some hemodynamic changes like elevated left ventricular and left atrial filling pressure. So there's going to be systemic inflammation. There are going to be changes in neurohormonal systems, including the autonomic nervous system. And many of these conditions are going to lead to left ventricular hypertrophy, diastolic dysfunction, left atrial enlargement. As a consequence of these processes, there is going to be the development of fibrosis in the atrial tissue, and this is going to create the substrate that can make the development of atrial fibrillation more likely to occur in the presence of specific triggers. In addition to this, these mechanisms also can lead to electrophysiologic changes in atrial tissue, what we call electrical remodeling, that will also result in an increased risk of atrial fibrillation. In addition to the systemic effects, obesity can have local effects at the heart level by the presence and the increased volume of epicardial adipose tissue in persons who have obesity. And this is going to be not only increases in the volume, but also changes in the actual physiology of the adipose tissue that can result in different mechanisms through paracrine signaling at the local level that eventually are also going to lead to this atrial fibrosis, electrical remodeling, and an increased risk of atrial fibrillation risk. So this is just to give you an overview of the links between obesity and atrial fibrillation. Now I'm going to move to talk a little about obesity and sudden cardiac arrest. And I'm talking about sudden cardiac arrest in the context of cardiac arrhythmias, because one of the major reasons why people can have a sudden cardiac arrest and sudden cardiac death is the development of a ventricular arrhythmia. So again, just some definitions according to, as defined by the American Heart Association, a sudden cardiac arrest event is the sudden cessation of cardiac mechanical activity so that the victim becomes unresponsive with no normal breathing and no signs of circulation. If someone develops a sudden cardiac arrest and the condition is not properly treated, then that's going to result in sudden cardiac death. And we are talking again about, as I mentioned, about this here because ventricular arrhythmias are one of the most common causes of sudden cardiac arrest. Ventricular arrhythmias include things like ventricular tachycardia, ventricular fibrillation, and others that can result in this particular outcome. Sudden cardiac death and sudden cardiac arrest are important public health problems. There are over 250 to 350,000 sudden cardiac arrests annually here in the US, and more importantly, 90% of these events result in death. In addition, many of these events occur in individuals in which there is no prior diagnosis of cardiovascular disease. These can be the first manifestation of cardiovascular disease, and therefore prevention and identification of individuals at higher risk is important. Because of that, as we were talking earlier about atrial fibrillation, there has been a lot of interest in understanding what are the factors that increase the risk of sudden cardiac death. And in that line of research, obviously obesity, again, as a potential risk factor for multiple cardiovascular diseases, has been linked, has been studied in the context of sudden cardiac death. And what you can see here in this more or less recent meta-analysis, looking at multiple different population observational epidemiological studies that explore the link of obesity and sudden cardiac death, is that most of them consistently found an increased risk of sudden cardiac death in individuals with higher BMI levels. Here you have the summary estimate from this meta-analysis was around a 1.16 relative risk, which corresponds to a 16% increase in the risk of sudden cardiac death, in this case per increasing 5 units of BMI. And again, you have this nice, clear linear relationship between BMI and the risk of sudden cardiac death in the range of BMIs between 20 and higher. Obviously, people who have lower BMIs, they may have a higher risk of cardiovascular disease, including sudden cardiac death, through other mechanisms. In contrast to what we were mentioning earlier, for atrial fibrillation, we don't have the same level of evidence regarding causality with Mendelian randomization studies and sudden cardiac death and obesity, but still the evidence is quite consistent and suggested that this may be a causal association. What about the link between obesity and outcomes in individuals who suffer a sudden cardiac arrest event? In theory, and in practice, and there are studies that suggest that in people with obesity, some of the interventions that we use to treat individuals who suffer sudden cardiac arrest, like chest compression, airway protection, and then the use of the defibrillation may have worse likelihood of success because of the excess body mass. And in fact, there have been some studies that have found that in individuals with class 3 obesity, who suffer in hospital cardiac arrest, outcomes may be lower. However, when we look at the overall epidemiologic evidence, it has been suggested that individuals who have slightly elevated levels of BMI in their overweight or class 1 or maybe class 2 type obesity, they actually may have similar or even better outcomes than those who have a normal BMI. And this was mentioned earlier today in terms of the obesity paradox. And this may be due to potential selection biases that occur in these studies, but also that having some degree of body weight and increased body weight may be protective in individuals who already have chronic conditions. What are some of the pathways linking obesity and sudden cardiac death? Some of the pathways that have been already, they are similar to what we were talking about earlier when we were discussing atrial fibrillation. One of them is that individuals with obesity are going to have left ventricular hypertrophy, and that can increase the risk of ventricular arrhythmias. There is also the impact that the epicardial adipose tissue is going to have in the increased risk of ventricular arrhythmias. For example, there can be infiltration of the ventricular myocardium that can lead to fibrosis, facilitating the development arrhythmias, there are going to be electrophysiologic changes at the ventricular level that can increase arrhythmic risk, including QT prolongation, the development of premature ventricular complexes, QRS fragmentation as a consequence of that, fibrosis, and other factors that we know that may increase the risk of ventricular tachycardia, ventricular fibrillation, and other arrhythmias. And finally, obesity again can lead to changes in the autonomic nervous system, and we know that changes in the autonomic nervous system can work as function as triggers for the development of some arrhythmias, atrial fibrillation, but also ventricular arrhythmias. All right, so now going to the final part of my presentation, in which I would like to cover some of the evidence we have right now about the impact that weight loss may have on the risk of arrhythmias. So let's start talking about atrial fibrillation, obviously because there have been so many studies that consistently found that individuals with obesity have a higher risk of developing AFib. A follow-up question to that will be evaluating whether weight loss was associated with a decreased risk of atrial fibrillation. And there have been mostly observational studies that have tried to answer this question. And here in the left side in the left panel of this slide, you see a meta-analysis of mostly observational studies. And what you can see looking at all these studies is that when they were looking at individuals who lost 5% weight or looking at 5% weight loss over time, what they found is that this was not associated with an increase or a decreased risk of atrial fibrillation. The hazard ratio, combined hazard ratio, was 1.04, which will correspond to no effect with a non-significant confidence interval. And you can see that the results were pretty consistent across all the different studies. There has been only, in this meta-analysis, and to my knowledge, there is only one individual randomized trial that explored the effect of a weight loss intervention on atrial fibrillation risk. And this is this study here, which was a post-hoc analysis of the Look Ahead trial, which many of you may be familiar with. This trial that included people with type 2 diabetes and had the focus of determining the effect of an intensive lifestyle intervention focusing on weight loss on the risk of cardiovascular disease. Atrial fibrillation wasn't one of the primary endpoints, but the investigators collected information on that endpoint, and an analysis that explored that specific endpoint found that in the intervention compared to the control group, there was no difference in the risk of atrial fibrillation. And obviously, these kinds of results are in some way inconsistent with the epidemiologic evidence of finding a lower risk of atrial fibrillation in those with normal weight or higher risk in those with obesity. And potential explanations are that one, in many of these studies, the amount of weight loss, which many times is around 5%, no larger than that, may not be enough to really counteract the negative effects of obesity on the potential risk of atrial fibrillation. And the second potential explanation is that by the time these weight loss changes occur or these interventions take place, the damage to the cardiac structure and function has already occurred and may not be reverted or may not be able to be reverted in a meaningful way through just small weight loss interventions. An additional piece of evidence that helps us understand better what the impact of weight loss on the risk of atrial fibrillation is studies that have looked at individuals undergoing bariatric surgery. Obviously, in people who have this kind of surgery, the amount of weight loss is going to be much larger than what we can see with traditional weight loss interventions. And in those cases here, you have examples from two separate studies. Those studies have found that those individuals who underwent bariatric surgery had over time a much lower risk of developing atrial fibrillation. So in this case, there was between a 20 and a 30% reduction in the risk in these two separate studies. And you can see that these studies had a very long follow-up and had significant reductions in the risk of atrial fibrillation. Meta-analysis, recent meta-analysis, including multiple studies, including these two studies, found that among individuals undergoing bariatric surgery, there was a 34% reduction in the risk of atrial fibrillation compared to those who didn't. A limitation of these kinds of analysis is that these are observational, and individuals who undergo bariatric surgery may be different from those who don't in ways that make them less likely to develop atrial fibrillation. So in the absence of randomized experiments, we need to maybe decrease the level of confidence we have on this. on these results. What about patients who already have atrial fibrillation? Does weight loss have a role here? And the answer is that yes, actually, we have better evidence that weight loss interventions in patients with AFib can be beneficial. There have been a number of studies here. You have two separate studies from a group in Australia that has done a lot of research in this area. And in these two different studies, they studied two different cohorts of patients with atrial fibrillation. And these patients were offered the possibility of participating in a risk factor management program that had weight loss as a major component. And in both cases, both the involvement in the risk factor management program and the amount of weight loss that was obtained as a consequence of participation in that program led to better outcomes in these individuals, whether it was lower recurrence after ablation or overall lower burden of atrial fibrillation over time. In addition to these observational studies suggesting that weight loss may be beneficial in patients with AFib, we also have one small randomized trial that looked at a risk factor management intervention, again, that had a major weight loss component in patients with atrial fibrillation. And this trial was shorter in time. This was 15 months of follow-up, but the trial found that those assigned to the intervention had lower burden of symptoms related to their atrial fibrillation, had lower burden of atrial fibrillation, of the arrhythmia at the time that they were on the arrhythmia. And also the trial demonstrated that there were changes in cardiac structure and function that will result in, that will could explain that lower burden of disease. These studies and other studies have actually led to the most recent guidelines for the treatment and management of patients with atrial fibrillation to include weight loss interventions in the context of overall risk factor management as a recommended activity in patients who have excess body weight and have atrial fibrillation. And what do we know about sudden cardiac death and weight loss? In this area, actually, there is more limited information. We don't have any published evidence linking weight loss to changes in the risk of sudden cardiac death. However, we know that weight loss is associated with reduced epicardial adipose tissue, reduced left ventricular hypertrophy, and reductions in ventricular repolarization heterogeneity and other electrophysiologic changes. And all these mechanisms may be likely to reduce sudden cardiac death risk, and therefore it is possible that weight loss may be beneficial also in these cases. But again, we don't have direct evidence linking weight loss and sudden cardiac death. And I wanted to finish my presentation just talking about what has been published so far about the link between GLP-1 receptor agonists and other incretin-related drugs and the risk of arrhythmia. This is mostly coming from published studies on GLP-1 receptor agonists and trying to collect data from the different studies. And the meta-analysis that have been published on this area in general have not found that GLP-1 receptor agonists are associated with the risk of arrhythmias. This is just this is already a little old, so probably there is going to be obviously more data that should be added to this. But overall, just looking at these initial trials, what you can see is that there was no overall association between GLP-1 receptor agonists and the risk of arrhythmias. And then when we look at atrial fibrillation specifically, the investigators didn't find an effect, and the same specifically for ventricular arrhythmias, whether it's ventricular fibrillation or ventricular tachycardia. One point to note here is that in general, arrhythmias have not been considered as primary endpoints in any of these trials, or even sometimes even secondary endpoints. Some of them are just considered safety endpoints, and therefore the quality maybe of the ascertainment and the adjudication of these events may be different from what you would expect from primary endpoints. So therefore, future trials, if we want to have a better understanding of the link of these drugs on arrhythmia risk, should really consider adding arrhythmias to the list of endpoints that are going to be ascertained. In fact, when you try to go through these trials and find the results related to atrial fibrillation, is actually on another arrhythmias is difficult to find, even if they present them at all. So just to end, I wanted to highlight potential knowledge gaps that could be derived from what I have been talking today. First, even though we have some understanding of the potential potential mechanisms that link obesity and arrhythmia risk, I think that there is still a lot of room to improve that knowledge and really determine what are the important factors, because that's going to be obviously relevant to determine preventive strategies and identify individuals more likely to benefit from interventions. We really need to have a better understanding of the potential of the effect of weight loss on sudden cardiac risk, sudden cardiac death. Sudden cardiac death is a major public health burden, and trying to figure out whether weight loss may be beneficial is probably quite relevant. Obviously, we need better information on the role of new drugs such as GLP-1 receptor agonists and dual GIP-GLP-1 receptor agonists on arrhythmia risk. That's still an area of future research. And finally, better understanding of of what we call endophenotypes in patients who have atrial fibrillation or who have ventricular arrhythmias. By that, I mean different subtypes of atrial fibrillation, trying to understand better what those subtypes are and how specific risk factors like obesity are linked to those different subtypes may be relevant for prevention, to identify patients that may be more susceptible and may benefit more from specific interventions for that focus on weight loss. That would be also an area of interest. And with that, I will finish my presentation. Thank you.
Thank you so much, Dr. Alonso. That was a really comprehensive talk about what I think is an underappreciated complication of obesity. I want to talk a little bit about this, the data you showed on bariatric surgery versus lifestyle intervention, and the fact that bariatric surgery showed a difference, whereas in look ahead, the lifestyle intervention did not. And wondering if maybe we could talk a little bit about a potential threshold effect, because we actually did a secondary data analysis of the look ahead data and found that, the weight loss at 1 year in those who lost 10% or more of their initial weight, they actually did have a lower risk of our primary cardiovascular outcome. And with the GLP data that you showed, I noticed that those were when the drugs were being used for diabetes, and either they were the less effective drugs for weight loss or at lower doses. And the newer drugs, you do get that 10% or more weight loss, and wondering what the potential is there that maybe you do need that threshold of weight loss to see an impact.
No, I totally agree. I mean, and I think I was involved in the look ahead analysis that looked at atrial fibrillation, and we really wanted to, because when we went to that analysis, our hypothesis was we have this very strong association between obesity and atrial fibrillation. We should see, even if we don't see the effect for the primary endpoint, we were hoping to see something for atrial fibrillation, and we were surprised that we didn't find anything at all. And we also tried to look at what happens in the people who actually lost more than 10%. And for this particular endpoint, the problem was that we didn't have enough events. That within the context of look ahead, it just wasn't enough. So it is difficult. Right now we haven't had data from lifestyle interventions in people that lose enough weight to tell us that. But obviously it makes sense putting together the bariatric surgery data and the lifestyle intervention data, that there is probably some degree of threshold. And maybe just traditional lifestyles that achieve 5% reduction risk is not going to be enough for that. Obviously, they have many other benefits, right? Regarding the GLP-1 receptor agonist, I mean, I'm sure that when we look at this in the context of the entire evidence, my hunch is that we'll see an effect. One thing I will encourage people to do when they are involved, those that are running these studies, is that actually look at arrhythmias and include arrhythmias in the results. I was looking at the results from the SELECT trial, and there is nowhere where they published information on atrial fibrillation as an endpoint. And and sometimes the problem is that people don't consider it as an important event and the same level of a stroke or coronary artery disease or heart failure, and I understand that, but also, this is an important condition, and definitely this is something that going forward, it would be great if more trials collected good information on the incidence of arrhythmias and reported those those data. And my guess is that, yeah, we'll see when we see that over time in the same way that we see that it has an impact on other cardiovascular endpoints, it will have an impact on atrial fibrillation because of the connection that we have there between all of them. Mm-hmm.
Great, thank you. We have one more question, which was about sex differences in cardiac arrhythmias. I wonder if you can address that.
Yeah, so I mean, in terms of, there is one thing that in terms of the risk of having cardiac arrhythmias, particularly atrial fibrillation, we actually see that the rates tend to be higher in men than women. Interestingly, one of the explanations that have been suggested to explain that difference is that men on average are taller than women, and we know that height and body length is actually an important risk factor for atrial fibrillation because it impacts the size of the left atrium, and the larger your left atrium is, the higher your risk of atrial fibrillation. And there is this yeah, I'm not going to go there, but yeah, we know that, and those sex differences for the incidence of atrial fibrillation are likely to be due to differences in body size. In terms of outcomes in patients with atrial fibrillation, there has been some studies that suggest that women tend to have a higher risk of a stroke than men when they have atrial fibrillation, and that's something that sometimes is considered in the management of patients with atrial fibrillation. I don't think we have good evidence, or there is any evidence to suggest that the link between obesity and the risk of arrhythmias is going to be different in males or females. So in that sense, I think it's probably the same. Mm-hmm.
Great. Well, thank you again. And we're now going to take about a 10-minute break, and we're going to reconvene at 11 for our next talk. Great. I'll turn it over, to Dr. Sharoma to introduce you, Dr. Linkhoff.
Okay. Well, welcome back, everyone. Hopefully you got a quick bio break and a chance to grab a coffee or a Diet Coke in my case. Moving on to our next speaker, it's my privilege to introduce Dr. Michael Linkhoff, who is the Vice Chair for Research and an interventional cardiologist in the Department of Cardiovascular Medicine at the Cleveland Clinic. He's a professor of medicine at the Cleveland Clinic, Lerner College of Medicine at Case Western Reserve University, and holds the Charles and Charlotte Fowler Endowed Chair for Cardiovascular Research. His research activities focus on the development of metabolic and antithrombotic therapies to prevent or reduce progression of atherosclerosis and optimize management of acute coronary syndromes or percutaneous coronary interventions. He has served as principal investigator and steering committee member for over 50 clinical trials of ischemic and cardiometabolic diseases. Dr. Linkhoff's title this morning, almost afternoon, is entitled Nutrient-Stimulated Hormone-Based Therapies in the Prevention of Obesity-Related Cardiovascular Disease. Please help me welcome Dr. Michael Linkhoff.
Thank you very much. Let's see if this share works. Can you see my screen? My slides?
Yes, we can.
Okay, great. So thank you. I appreciate the opportunity to talk a bit about the GLP-1 receptor agonists in cardiovascular disease. I'm going to be staying away primarily from the issue of heart failure, as my colleague Barry Borlag will be talking about that in a subsequent lecture. But I'll talk within the context of the SELECT trial briefly. My relationships with industries are shown here. So the glucagon-like peptide 1, which is produced predominantly by the neuroendocrine cells, control glucose metabolism and energy homeostasis through regulation of a variety of functions, islet hormone secretion, gastrointestinal motility, glucose uptake, and also CNS mediators of food intake, prompting development of these agonists for this receptor for treatment of diabetes and then also ultimately for obesity. GLP-1 also suppresses inflammation, and there's receptor signaling in multiple tissues that can independently impact cardiovascular function. The most potent of the agents have been tested in a number of trials in diabetes, and the cardiovascular outcome trials were in diabetes initially, in patients with type 2 diabetes. And those showed in this meta-analysis that there was a significant reduction in the risk of cardiovascular events, in addition to improvements in glycemic control and also weight loss in some of these studies as well. And so the finding of about a 14% risk reduction overall led to the question of whether or not, in the absence of diabetes, but given the similar metabolic milieu of overweight and obesity, even without diabetes, would these agents have impact on cardiovascular outcomes as well in patients with overweight and obesity who do not have diabetes? Semaglutide, 2.4 milligrams, is the most potent of the single receptor agonists. And in phase 2 trials and phase 3 weight loss trials were shown to have substantial effects on the mediators that might be expected to influence cardiovascular outcome. Reductions in body weight in the range of about 12 to 13%, substantial reductions in blood pressure, and also effects on inflammation as reflected in C-reactive protein. This was the motivation then for testing semaglutide as the proof of concept for the question of whether or not the GLP-1 receptor agonist in the setting of overweight or obesity but without diabetes would influence cardiovascular disease outcomes. And this was tested in this trial, the SELECT trial, among patients who had pre-existing cardiovascular disease. Patients were eligible for enrollment in the study if they had a body weight of a body mass index of 27 kilograms per meter squared or higher, had established cardiovascular disease as defined by a prior myocardial infarction, a prior stroke, or symptomatic peripheral vascular disease, and who did not have diabetes, prior diabetes diagnosis, or a hemoglobin A1C of 6.5% or greater at screening and enrollment. And we enrolled patients of 45 years of age or older. They were randomized to receive semaglutide 2.4 milligrams once weekly. That's the weight management dose, or placebo in a blinded fashion, with the dose escalation over a period of 4-week intervals of semaglutide to the full 2.4 milligram dose. This was an event-driven trial which was designed to detect at least a 17% reduction in the primary efficacy endpoint, which would require 1,225 first MACE events. We enrolled 17,604 patients in 804 sites in 41 countries. The primary endpoint was major adverse cardiovascular events, or MACE, which was death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke, analyzed in a time to first event analysis. And then we had hierarchical testing of confirmatory secondary endpoints, which included cardiovascular death, a heart failure composite, or all-cause mortality. The patients were well balanced, as would be expected with a trial this size. The average age was 61 years, 27% were women. 71% of patients met the BMI criteria for obesity, that is over 30 kilograms per meter squared. And 2/3 met the hemoglobin A1C criteria for prediabetes. Recall that patients with diabetes were not included. Over 3/4 had a prior myocardial infarction. They were well treated at baseline with standard of care therapies. Their systolic blood pressure on enrollment was 131 millimeters mercury. Nearly 90% were on statin therapy, and the median LDL cholesterol at enrollment was 78 milligrams per deciliter. Patients were followed over a period average of 39.8 months. The study drug exposure was slightly lower in the semaglutide arm, 33 months versus 35, by virtue of the higher rate of study drug discontinuation, which I'll get to later in this presentation. The primary endpoint, the cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke, was significantly reduced. The hazard ratio is 0.80, so a 20% relative risk reduction from 8% to 6.5% in the semaglutide arm. Note that the divergence of the survival curves began to accrue very early after initiation of therapy and proceeded in a continuous fashion, a constant hazard reduction thereafter over the course of the study, with a highly significant p-value for superiority of semaglutide. The benefit in terms of the primary endpoint was concordant across all of the subgroups that were tested in the trial. including sex, age, the BMI at enrollment, that is whether they were overweight or obese, and the severity of obesity, and then the presence or absence of prediabetes as defined by hemoglobin A1C. The first of our confirmatory secondary endpoints was death from cardiovascular causes. And for this, the hazard ratio was 0.85, but the confidence interval did cross the line of unity with an upper limit of 1.01. So this was not significant. Subsequent testing, thus, is not hypothesis testing. Now, this also, the confirmation of these survival curves had the curious finding of initial divergence, then a convergence, and then finally a divergence to the final outcome. Overall mortality, death from any cause, was reduced with a hazard ratio of 0.81, the upper limit of the confidence interval of 0.93. And so this is an interesting finding that we looked into more detail in a recent publication by my colleague Ben Sirica. So this shows again the all-cause mortality, which shows the general divergence, whereas the cardiovascular mortality had this transient convergence, sort of in the middle of the time period. So for all-cause mortality to be reduced, of course, non-cardiovascular death was reduced by a similar fashion with a hazard ratio of 0.77 that was significant over the course of the study. These non-cardiovascular deaths were primarily deaths related to infection and primarily related to COVID-19. So 4,200 patients reported COVID-19 infection over the course of the study, with no reported difference between the two arms. However, there was a significant reduction in the risk of mortality associated with COVID with semaglutide, with a hazard ratio of 0.66 that was, as I say, significant. So what in effect happened, these graphs show not over the time from randomization, but over calendar time. In the initial part of the study before the COVID pandemic, cardiovascular death was lower in patients who were receiving semaglutide as it was after the period of the pandemic. During the period of the pandemic, however, the non-cardiovascular deaths emerged as more frequent than the cardiovascular deaths, and there was a significant reduction in that time period with the patients who were having received semaglutide. So overall mortality was reduced, driven by similar reductions in cardiovascular and non-cardiovascular death. But the lower rate of non-cardiovascular death with semaglutide, predominantly due to fewer infections and particularly COVID, seemed to act as a competing risk for cardiovascular death during that time period of the pandemic, and may be what explains the transient convergence of the cardiovascular death incident rate during that time period. We had a heart failure composite as well. This was defined as cardiovascular death or hospitalization or urgent visit for heart failure. This was reduced with a hazard ratio of 0.82. The convergence in the center here reflects the cardiovascular mortality component of the study. Among patients in the trial, the 17,000, 4,200 patients did carry a diagnosis of heart failure at baseline. Now, this was not a rigorously defined diagnosis as in a heart failure trial. This was designated by the investigator at the time of enrollment. 2,200 designated as heart failure with preserved ejection fraction, 1,300 with reduced, and unclassified, and 666 patients. Among those patients with heart failure as compared to no heart failure, the reduction in MACE was significant as well as it was this heart failure composite, and the event rates were higher for patients with heart failure, and there was more of an effect on the heart failure composite in those who had a pre-existing diagnosis of heart failure. So the presence of heart failure certainly did not diminish, and if any, it did not diminish the ischemic protection with regard to MACE, and if anything, enhanced the protection with regard to the heart failure composite. Looking at the types of heart failure, that is those with HFrEF versus those with HFpEF, again, not rigorously defined as in a trial dedicated, but you can see among those patients with HFrEF, the MACE rates were substantially higher and were reduced, as was the heart failure composite. And this provides a fair amount of reassurance, particularly given concerns in the past of whether or not treating patients with HFrEF with weight-reducing drugs was actually beneficial. This question of a paradoxical effect in patients with heart failure and reduced ejection fraction and the potential for harm. And the findings from this study among that group of patients suggest that there was no harm and substantial benefit by the weight loss and the treatment with semaglutide in that group of patients. There was also benefit with regard to a kidney composite. We used a 5-component kidney composite in this study that included a variety of things. But the effect was significant with a reduction, a hazard ratio of 0.78, driven primarily by the onset of persistent microalbuminuria, although also with an effect on GFR. The recently reported FLOW trial, of course, addressed the issue specifically among patients who had chronic kidney disease and diabetes in a much more definitive and rigorous fashion. In this, among patients, driven to 3,500 patients with 854 outcome events, they showed substantial reductions in the risk of a kidney-specific component endpoint, and also a slowing of the deterioration in GFR, or the GFR slope, as well as concordant findings with what we had seen with SELECT in terms of the ischemic endpoints. Safety in this study, of course, this was the largest trial in terms of the number of patients and the degree of follow-up for GLP-1 receptor agonists, and safety, of course, is an important concern, and there have been concerns in the popular press with the safety of these drugs. There were no differences, or certainly no differences in non-cardiovascular serious adverse events, and of course, advantage with regard to cardiovascular disorders. So overall, SAEs were reduced in the semaglutide group. Adverse events leading to study drug discontinuation, however, were higher with semaglutide, as expected, with a higher rate of gastrointestinal events that led to study drug discontinuation, 10% versus 2%, usually during the period of dose escalation. So there is a discontinuation rate that is related to intolerance. There was also a higher rate observed of gallbladder related disorders. These were cholelithiasis, not cholecystitis. But there was no difference in serious adverse gastrointestinal events, and also events of special interest such as acute pancreatitis, also neurologic or psychiatric or malignant disorders as well. There was no difference between the groups. So from the overall top-level findings of the study then, we were able to conclude that in patients who had pre-existing cardiovascular disease and overweight obesity, but who did not have diabetes, once-weekly subcutaneous semaglutide, 2.4 milligrams, significantly reduced the risk of cardiovascular death, myocardial infarction, or stroke by 20%, a benefit that occurred early after initiation of treatment and was concordant across the subgroups and the various endpoints. We had no unexpected safety findings or greater risks of serious adverse events. The mechanisms, of course, of cardiovascular reduction with semaglutide remain speculative and are important not only from the standpoint of individual patient management and decisions regarding continuations of drugs in relation to what their weight loss is, but also in the development of new agents and next generation agents to improve cardiovascular outcome. Certainly, semaglutide reduced weight, and that was, of course, one of the primary effects, non-cardiovascular effects in this group of patients with overweight and obesity. There was about a 10 to 11% reduction in weight, which was sustained over the entire period of follow-up. This weight reduction, though, peaked at about 65 weeks, and then was sustained thereafter with similar reductions in waist circumference. Waist circumference, in fact, among those who started with a BMI less than 35, waist circumference was shifted into what's considered a cutoff point, a healthier metabolically cutoff point in 41% of patients on semaglutide, as compared to half that rate or lower rate in patients on placebo. So a shift in the metabolic parameters that would be expected to improve cardiovascular outcome. Nevertheless, the cardiovascular benefits of semaglutide appeared to be largely independent of the extent of weight loss. Whether patients had lost 5% or more of their body weight, or if they had lost less than that or even had weight gain, they had similar reductions in their MACE events. Now, by this forest plot, it looks like there may be more of an effect in those patients who had the higher body weight loss. But in fact, that reflects the fact that the worst outcome was in placebo patients who had a body weight loss of greater than 5%. So those patients actually did worse, and it probably reflects what was the underlying reason why a patient on placebo would lose more than 5% of their body weight. What's most important and perhaps most relevant is for the semaglutide curves, whether they were patients who lost 5% or less, or gained weight, or those who lost more than 5%, they had exactly superimposable outcome curves. So the cardiovascular outcome with semaglutide appeared to be largely independent of the magnitude of weight loss. And there are some preclinical data to support this as well. In mice, LDL receptor deficient mice who develop atherosclerosis, there was a dose-dependent effect on body weight, as shown in the left-hand curve, but the effect on plaque lesion area was independent of body weight. I'm sorry, it was independent of dose, and thus the anti-atherogenic effect appeared to be independent or unlinked, at least in part, from the effect on body weight. Well, there was improvements in glycemic control as well, and that may be expected to improve cardiovascular outcome. This was, again, a group of patients who did not have diabetes, but 2/3 of them had prediabetes. There was a reduction in A1C on average of 0.3%. The progression to biochemical diabetes, that is a hemoglobin A1C of greater than 6.5%, was reduced substantially by over 70% by patients receiving semaglutide. And the progression to prediabetes among patients who do not have prediabetes at baseline was also reduced by over 60%. Moreover, regression of prediabetes, that is, of the 2/3 of patients who had prediabetes, regression occurred in 2/3 of those among those who were treated with semaglutide, whereas a small percentage, 21%, had regression of prediabetes in the placebo group. So these glycemic control indices might be expected to improve cardiovascular outcome. But again, that turned out to be very difficult. In a recent publication by my colleague, Ildi Lingve, the baseline glycemia, dysglycemia, did not influence the treatment effect. Treatment effects was identical regardless of whether patients did or did not have prediabetes and the extent of prediabetes. But moreover, the change in hemoglobin A1C over the first 20 weeks did not significantly influence the magnitude of benefit of the MACE reduction as well. Now, these are always post-hoc analyses, both the weight and for the glycemic control that I'm showing you here. These are all it's as a post-hoc event, that is weight loss or glycemic control. There's always the possibility that the groups are no longer comparable. But to the extent that we can analyze, we see little in the way of determination by the extent of weight loss or by the extent of glycemic control. Other cardiovascular risk factors were also influenced. Blood pressure was reduced by 3.3 millimeters, which would be expected by the meta-regression analyses that have been previously published to have an influence on cardiovascular outcome. There was minimal effect on lipids aside from triglycerides, and inflammation was reduced by 37% in terms of CRP. And this is on top of statin therapy in the majority of patients. The reality is that we don't know, and we can't know from one trial. We know that GLP-1 receptor agonists have multiple indirect systemic effects, which could favorably influence cardiovascular outcome, many of which I've shown you here, in addition to natriuresis, coagulation effects, and of course, the effects on postprandial lipids, et cetera. But there are also direct cardiovascular effects on vascular tissue and myocardium, which may influence cardiovascular outcome as well. There are interesting effects that may be related more to behavior as well. In this study of food choices among patients after starting GLP-1 receptor obesity modifying agents, they showed a spontaneous shift in the choices of consumers to healthier foods, to more in the way of fruits, vegetables, poultry, and fish, and substantially less in choices of calorie-dense products such as sugars and cookies and candies and carbonated drinks. So these effects also may have influence on their cardiovascular outcome. Of course, there's more than GLP-1. And there are a number of gut hormones that influence cardiovascular outcome as well as the overall cardiometabolic milieu that have become the topic of interest for the next generations of these agents. And these include the glucagon receptor, GIP receptor, and amylin receptors, which have at times complementary or at times perhaps counter-regulatory effects on each other in the various tissues. The tirzepatide produced by Lilly is the agent that is available currently commercially and is approved for both weight loss and for diabetes and is currently under evaluation in large-scale cardiovascular outcome trials. This agent, a dual receptor of GLP-1 as well as the glucose-dependent insulinotropic polypeptide, has been shown to have profound effects on weight loss, more in the way of the single receptors, as well as hemoglobin A1C reduction, as shown here with reductions in weight by as much as 21% at the highest dose group, and is currently under evaluation in both a large-scale trial for diabetes as well as the SURMOUNT-MMO trial, which is in the setting of patients with overweight and obesity. This enrolling patients not only with those with established cardiovascular disease, but also with multiple risk factors, and hopefully will provide interesting information regarding primary prevention as well. But of course, there's been a flurry of development of newer agents as well, and driven by the effects, the successful effects that have been seen with the existing drugs with semaglutide and others. These attack multiple receptors, at times agonists, at times, for example, with the Amgen product, an antagonist and an agonist, monoclonal antibody preparations, also oral preparations, which are of great interest, of course. And then, as I'll talk very briefly in a moment, the myostatin inhibitors as well. Amylin is an interesting target. This is a satiety hormone and co-secreted by the beta cells and binds to the area in the hypothalamus to promote satiety. And in a combined agent, CagriSema, this cagrilintide and semaglutide, shows complementary effects and additive effects in terms of reduction in both body weight and hemoglobin A1C, and is an evaluation for cardiovascular outcome data. A triple receptor agonist, glucagon, GIP, and GLP-1, retatrutide, was tested showing its effects on cardiovascular outcome in phase 2, is currently in phase 3 studies. And as my colleague Anya Jastreboff pointed out, she's never had a study before where 100% of patients responded at a regulatory level of weight loss. And so a very profound effect of this agent. Of course, oral agents are in demand and of great interest on the part of patients as well as practitioners in terms of ease of administration. Semaglutide, despite being a peptide, actually can be administered as an oral agent. It's a complex formulation with very low bioavailability, but at the high dose, it does result in substantial weight loss. But of course, there are non-peptide GLP-1 receptor agonists, which may be easier to formulate and have higher bioavailability and have also been shown to result in substantial weight loss. Although this is not a slam dunk, there's a substantial incidence of nausea and GI intolerance with these agents as well. And so titrating and proper dosing in terms of escalation and understanding the right balance may be very important. Finally, I'll just close with comments on the issue of preservation of muscle mass. It's very clear we focus on the weight loss and on the fat loss, but it's very clear that weight loss also involves, regardless, all calorie reducing weight loss processes also result in reduction in lean muscle mass by perhaps as much as 20-25%. And that may not necessarily recover in patients who then regain. And so cyclical weight loss may result in substantial reductions in lean muscle mass out of proportion of the fat mass, and may be responsible for what's been clearly observed as worse outcome in patients who have cycling of their weight. The myostatin activin receptor pathway seems to be an interesting pathway to preserve muscle mass. The Belgian blue bull has a frame shift deletion in the myostatin sequence that eliminates virtually all of the active region of this molecule. And you can see a muscle mass that many of our patients perhaps would love to be able to see, to have for themselves. And so presumably this type of agent may be helpful in preserving muscle mass at the same time as weight loss. And in fact, had been tested in one study, bimagrumab, which is a monoclonal antibody. This was in a study of patients who had a BMI of 28 to 40 and type 2 diabetes, and who were randomized. This is without a GLP-1 receptor agonist, but to bimagrumab or placebo. And then were found to have total body fat mass that was decreased by 21% as compared to 0.5% in those with bimagrumab. But interestingly, they had actually an increase in lean muscle mass at the same time as the substantial reduction in fat mass. So this is a very interesting new avenue, and I know that at least one company, but likely several, are looking into combinations of these approaches with GLP-1 receptor agonists. So where we stand, though, now is that semaglutide at the 2.5 milligram dose is the first weight management strategy that has been proven in a rigorous trial to reduce the risk of cardiovascular events. And this now establishes overweight and obesity as a modifiable risk factor for cardiovascular disease. There are various estimations of the number of patients that could be affected by this, but an NHANES survey estimated at least 4.7% of US adults meet the selection inclusion criteria in 2017 and 2020. We're talking many millions of people, and certainly worldwide. And so we now, as practitioners who care for patients with cardiovascular disease, have to move beyond the traditional risk factors that we have been treating all along, the acquired and the genetic risk factors, and move now recognizing overweight and obesity is a modifiable risk factor. And at this point in time, the therapy that is proven to have effectiveness in reducing the cardiovascular risk associated with that is semaglutide. Thank you very much for your interest.
Thanks so much, Dr. Linkop. And I just can't I can't overstate the impact that the SELECT trial has had on this field and the excitement it generated, as you say, being the first obesity treatment that was demonstrated to have an impact on cardiovascular endpoints in a rigorous RCT. So thank you for that. We've got a number of questions. I'm just going to I think we just have time for about 2, but Dr. Linkop, I hope you'll be there for the panel discussion at 2 o'clock.
I will try.
And we can have some of those at that time. Dr. Khan, do you want to unmute yourself and ask your question?
Sure. Thank you for that really wonderful talk and overview. It's really exciting to see all of these results come together. I think one of the things that comes up a lot clinically and within the trials is this discontinuation that we see at a very high rate. And I wonder a little bit about what that means for underestimation of the effect size and if there was more adherence. And also with the SELECT trial, it seemed like not everyone got to maximal dose. So just from the effect size, and then your thoughts, I think, on, from the implementation side of it's probably going to be even worse in the clinical setting than it was in the trial.
Well, it may or may not. I'm a cardiologist. When I talk to my colleagues who are experienced with dealing with these drugs and these agents, they often, we escalated the dose every 4 weeks, and they said they often, will spread it out longer, we'll move back and forth. We did allow patients to move back and forth, but within a trial, it's sort of a forced escalation. And so to some extent in practice, particularly with experienced practitioners, there may be a better tolerance. Nevertheless, there's no question these drugs have some degree of intolerance, and many of these patients will benefit from moving from one to the other. I've had patients back and forth between tirzepatide and semaglutide, and they tolerate one better than the other. And certainly once we have cardiovascular outcome data from tirzepatide, that would be meaningful. But it is an issue. Now, whether or not that'll change with newer agents, of course, is unclear. You're right. We didn't get everybody up to full dose. About 77% were on the full dose. Now, some had moved back and forth. But interesting, if you look at the FLOW trial, which was a 1 milligram dose, they had the same cardiovascular treatment effect. Now, it's a somewhat different population, but it raises the question of whether or not the cardiovascular benefits may not be as dose related as the weight benefits. And so, we need to do a lot more in this. But I think that, hopefully with improved experience with this, we can keep more patients on the drugs for the benefit.
I want to ask one more question from the chat, because we get this a lot, which is, what role lifestyle intervention like changes in diet and exercise had in these outcomes. And maybe you could say a few words about what type of lifestyle intervention there was in SELECT and whether you can tease that out.
Well, so that's an important point, because we didn't have a lifestyle intervention in SELECT. We had guidelines that adhered to different nations' standards, but they're for management of cardiovascular disease. And so we did not provide calorie guidelines and exercise guidelines, just the sort of healthy guidelines, because this is a cardiovascular megatrial. So this is the setting of what a cardiologist would be doing with these patients, and it's not going to have the same intensity or effectiveness of the lifestyle management. That's why, and almost certainly, there was much more weight loss in the weight loss trials of semaglutide than there was in this trial. So certainly, I think the potential for additive benefit is there, particularly for the weight loss. But this effect that we saw is really in a setting of, we're treating it just as we would treat their high blood pressure and their high cholesterol, but not with as much in the way of lifestyle. And of course, we know that lifestyle by itself doesn't work, given the data from Look Ahead and other studies.
Great, thank you so much. And I'm now going to ask Eric to introduce our final speaker for this morning.
Wonderful. Our next speaker is Dr. Barry Borlaug, and he is a cardiologist and heart failure specialist who is a professor of medicine at the Mayo Clinic in Rochester, Minnesota. His work focuses on the pathophysiology, diagnosis, and treatment of patients with heart failure and pulmonary hypertension, with particular focus on heart failure with preserved ejection fraction, or HFpEF. Dr. Borlaug's talk is entitled Obesity and Heart Failure with Preserved Ejection Fraction, Pathophysiology and Treatment. Please help me welcome Dr. Borlaug.
Okay, good morning, everybody. Let me share my screen. Oops, just taking a snip of your nice slides there, Mike. Okay, can you guys see this?
We can.
Okay, so I'm going to talk about obesity and HFpEF from pathophysiology to treatment, and these are my disclosures. Get this off the screen somehow. Okay, so this is sort of similar to a slide that Dr. Kahn showed earlier. Obesity, we know, is a risk factor for cardiovascular disease, and that's very much true for atherosclerotic cardiovascular disease, like we just heard about with SELECT. And this is data from MESA that shows that. So higher BMI at age 20, at age 40, or at baseline associated with an increased risk of atherosclerotic disease. And the same is true in heart failure, but look at the gain. Look at the slope of this relationship. It is much steeper. And indeed, we would argue that obesity, that the real dominant cardiovascular disease that's related to obesity is heart failure. And we've known this since Framingham, which showed that excess body weight was associated with greater risk of heart failure. Back then, we didn't have EF, so we didn't know whether it was HFpEF or HFrEF. More recent data really is showing us this evolving picture here, that it's more determined by an increased risk of HFpEF rather than heart failure with reduced ejection fraction, which is not as strongly tied to excess body weight. And then we also know that the presence of obesity is a strong risk factor for development of HFpEF in men and women, but for reasons that remain totally unclear, it's a greater risk factor in women than men. So it's bad for both. And this just raises the question, why is that the case? And there are many reasons, and it's not just one, it's really the combination of all of them. One of them is shown right here. This is a really old study, 1977. This is directly measured radio-labeled indicator dilution technique to measure blood volume. And you can see that as your body weight goes up, there is a very striking increase in your circulating blood volume. And the steepness of this relationship is even a little bit higher in women than men, but it's very true of both. So part of being obese is having an expansion of your plasma and blood volume. And if you've got things like diastolic dysfunction, that would be expected to make your filling pressures much higher and lead to more severe symptoms. We also know that obesity accelerates cardiac aging. And this is a study, a community-based study from a number of years ago, where we did echocardiography to estimate left ventricular diastolic chamber stiffness. That's what's plotted on the y-axis here in women and men at baseline, and then at a repeat study conducted 4 years later. The red is women, and this is men. Women have stiffer hearts than men on average. And you can see that over just 4 years of time, and this is not people with heart failure, this is just people out there in the community, there is a very significant increase in diastolic chamber stiffness present in both sexes, but the age-dependent stiffening is greater in women than men. The interaction term was significant. The only other thing that was correlated with the magnitude of left ventricular stiffening, other than time or sex was changes in body weight. So people who managed to lose weight over time were the only ones who maintained their diastolic chamber stiffness, and there was a direct correlation, as you can see here, between the extent of weight gain over time and the increase in estimated diastolic chamber stiffness. So this would certainly predispose to things associated with diastolic dysfunction like heart failure. So the question isn't really why does obesity lead to heart failure? The question is why don't more obese people have heart failure, and specifically HFpEF? And the answer is they probably do, but they are continuing to get blown off in the clinics. And there are many reasons for this. One is that people often just assume that people that are obese have shortness of breath related to obesity and that it's not due to heart failure. Another is that some of the surrogate markers we use to make the diagnosis of heart failure are different in people with obesity. So this is a study where we took invasively proven patients with HFpEF. They all had undergone invasive hemodynamic assessment to definitively ascertain the presence of HFpEF. And we saw that 37% of them had an NT-proBNP level below 125, which is supposed to be the rule-out value. And 60% had NT-proBNP values less than 220. So important clinical point here is we can't use NT-proBNP to exclude HFpEF, but this is clearly something that we see in the setting of obesity. Natriuretic peptide levels are very consistently lower in people with obesity, and this is at least in part related to this, increases in epicardial fat. So we all have this sort of genetic endowment ability to store energy as fat, and when we overwhelm that capacity in the normal depots, fat starts going in other depots, like the epicardial space, as shown in this very striking example from a patient who had HFpEF and multiple hospitalizations and eventually was made comfort measures because of recalcitrant heart failure. This combination of left ventricular hypertrophy, right ventricular dilatation, biatrial enlargement, and an increase in epicardial fat increases the total heart volume. And you see that here in the middle panel. So people with non-obese HFpEF have an increase in their total heart volume, but the obese HFpEF patients even more so. And when your total heart volume expands, your pericardium has to grow too. But if your pericardium doesn't dilate as much as your heart volume dilates, you get an increase in pericardial constraint on the heart. And you get this picture right here, which is what's called diastolic ventricular interdependence from pericardial restraint. So normally the interventricular septum bows over into the right ventricle because the pressure in the LV is higher than the RV. When you get an increase in this pericardial constraint, you get flattening of the septum in this D-shaped left ventricle. This is kind of like what we see in things like constrictive pericarditis. It's constraint from the outside, but it's not due to a fibrosed, diseased pericardium. It's due to this cardiomegaly related to this. Now, BNP and NT-proBNP are released in cardiac myocytes, predominantly in the ventricles, in response to stretch. But if you've got this increase in extrinsic restraint on the heart, you've got decreased stretch relative to the elevation in pressure. And that leads to a lower BNP level for any degree of wedge pressure or left atrial pressure. So this is a plot here, less obese patients, more obese patients. The more obese patients for any value of NT-proBNP have a systematically higher left atrial pressure estimated by the pulmonary capillary wedge pressure. And it's not just with NT-proBNP. We see the same thing with other echo Doppler metrics that we use to estimate filling pressures like EE prime ratio. So this also really contributes to the under-recognition of HFpEF and systematic under-detection of HFpEF in people with obesity. Now, many of the features of obesity phenotype of HFpEF are similar. They all have diastolic dysfunction, increased diastolic stiffness, whether you're obese or non-obese related HFpEF. But there are some other factors which are a little different. These patients tend to have more right ventricular remodeling, more eccentric right ventricular remodeling. There is more of a positive relationship between the hemodynamic abnormalities. So again, here, the wedge pressure or the left atrial pressure is directly correlated with body mass in people with obesity-related HFpEF, but not in people with not obese HFpEF. And we think that this is related in part to the volume overload that we showed you earlier in the talk here. These people have a stronger relationship, which is not present in the non-obese patients. Inflammation is strongly impugned in the pathophysiology and pathogenesis of HFpEF. And when you look at patients, this is from the STEP HFpEF trial, you can see that, so remember, an elevated CRP is above 2 milligrams per liter. On average, most patients with HFpEF have an increase in systemic inflammation measured by CRP, and there's a positive relationship. And people with HFpEF and a BMI of greater than 40, really the vast majority of them have significant systemic inflammation. And this is true with CRP, which is what we use most commonly, but also other inflammatory adipocytokines like IL-6, which is upstream, which causes the liver to release CRP. And this is a study where we relate IL-6 levels to body mass index as well. And some of the talks thus far have really dealt with the issues of the limitations of BMI as a measure of adiposity. And you can drill down on this better by looking at specific fat depots with this technology. So this is with DEXA scans. And in this study, we did that, and we compared patients with HFpEF based on their IL-6 levels into tertiles, and those falling in the highest tertile of IL-6, the strongest separator of them was an increase in body fat. And really, this was mostly that upper body fat, android fat, that is associated with more of a pro-inflammatory state, more insulin resistance. This was the kind of fat that was most strongly associated with HFpEF. So this has led to this idea that could these increases in abdominal visceral adipose tissue, could these be important? Could these explain the predilection for many older women to develop HFpEF, which is a demographic that we know is very much afflicted by this? So to explore this, we performed a case control study of 105 patients with HFpEF, all of whom had undergone invasive hemodynamic exercise testing and abdominal CT for clinical reasons. And we compared them to 105 age, sex, and BMI matched control patients. In men, there was a trend, but there was no statistically significant difference between men with HFpEF and BMI and age matched control men in visceral fat area measured directly by CT. But in women, there was 35% higher visceral fat area, even compared to women who are matched for age and body mass index. And here's an example of that. So here's two women, both quite obese, BMI 41, BMI 42, but you can see that the distribution of fat is much different here. The woman with HFpEF has a much greater increase in visceral fat area as compared to the control woman, where it's more subcutaneous depots of fat. So there's an excess quantity of visceral fat in women with HFpEF, but there were also qualitative differences in the relationship between visceral fat and the hemodynamic abnormalities of HFpEF. So now we're plotting the exercise left atrial pressure. So this is the most direct sort of continuous measure of heart failure severity that we can look at. And in men, there's no significant relationship between visceral fat area and exercise wedge pressure. But when we look at women, you can see the visceral fat is lower in women than men. So the span is much lower, but any increase in visceral fat in women was associated with a much greater increase in pulmonary capillary wedge pressure during exercise. Again, supporting a greater role in women with HFpEF of excess visceral fat. In addition to that, there are abnormalities in venous capacitance. So your normal person, has about 5 liters of blood percolating around in their body. About 70% of that blood sits in the veins. The veins are the biggest capacitor of blood. If you take the whole blood volume and you look at the volume, the component of that blood that just fills the vascular space to zero pressure, that's called the unstressed blood volume, or UBV. The volume of blood in excess of that increases pressure in the blood vessels is called the stressed blood volume. Okay. So when there's venoconstriction, the stressed blood volume goes up, the unstressed goes down. The ratio of stressed blood volume to total blood volume goes up. So this is a study where we measured this. We performed hemodynamic assessment, and we estimated stressed blood volume and unstressed blood volume directly in collaboration with Dan Burkhoff. And the red and the pink, these are patients with HFpEF, these are patients with control. The control patients had a ratio of the stressed blood volume to total of about 25%, which is normal. The patients with HFpEF had an increase in the stress blood volume, slightly higher total blood volume, but really the difference here was an increase in the stress blood volume. And these differences became even more dramatic during exercise. So what this means is they have more blood in their circulation, but there's also more venoconstriction in the venous capacitance vessels in the hepatosplanchnic bed, squeezing more blood into the central circulation, and you're bringing more blood back to a very stiff heart. You can imagine how that really contributes to the elevation in filling pressures that we see in these patients. We then performed regression analysis of, this is the ratio of stress blood volume to total blood volume. So higher value indicates lower venous capacitance. And in both patients with HFpEF and patients with non-cardiac dyspnea, there's a very significant positive relationship. So the presence of obesity is leading to greater abnormalities in venous capacitance, which also contributes to the state of heart failure. So that's the pathophysiology. What do we know about the treatment? Well, we've known for years from observational studies that there's a lot of circumstantial evidence that this could be a good thing. These are data from a meta-analysis that we published a couple years ago where we looked at old studies where they had performed direct invasive hemodynamics before and after weight loss. These were mostly studies from the 70s and 80s. These were not in people with heart failure. They were just obesity, but we saw pretty substantial reductions in right atrial pressure, estimated left atrial pressure, and pulmonary artery pressure. You would certainly expect that these would be very beneficial in people with heart failure. And these are data looking at cardiac function long-term after bariatric surgery. So bariatric surgery typically leads to 20-25% reduction in BMI. And we see there was not an improvement in left ventricular ejection fraction, but there are significant improvements in myocardial deformation and left ventricular mechanics, as well as right ventricular mechanics. There were also reductions in that epicardial fat and a decrease in that pericardial constraint. So this would all suggest that there would be benefits in patients with heart failure, but of course, these are observational studies, so heavy bias, and they're also, of course, in patients who don't have heart failure. So what do we know about those? And we now have a rapidly emerging database that started with this trial. So this is the STEP-HFpEF trial published last year in the New England Journal. This was a double-blind randomized controlled trial of semaglutide titrated to 2.4 milligrams once weekly versus placebo in patients with obesity-related HFpEF, EF of 45% or higher. They had to have objective evidence of congestion and heart failure, and people were excluded with unintentional weight loss or other or diabetes in this first study. There was a sister study called STEP-HFpEF diabetes. And the primary endpoints, dual primary endpoints of the STEP-HFpEF trial were quality of life, measured by the Kansas City Cardiomyopathy Clinical Summary Score, KCCQ score, and body weight from baseline to week 52. And it was a massively effective intervention. So we saw unprecedented 8-point improvement in KCCQ score, never before seen with any medical therapy in HFpEF prior to the publication of this study. And also, like the studies in patients without heart failure, very significant reduction in body weight. Somewhat lower magnitude in these patients in heart failure compared to patients without heart failure, but still a very impressive effect. Now, there were also confirmatory secondary endpoints, and these were two of the most important ones. This is the change in 6-minute hall walk distance. This is a measure of submaximal exercise capacity. And again, prior to this, no medical therapy in a large trial had really shown any benefit in 6-minute walk test. And here we see a 20-meter improvement as compared to placebo with semaglutide at 52 weeks, and about a 40% reduction in systemic inflammation measured by high sensitivity CRP. So a very consistent improvements across all of these different domains. We subsequently looked for dose response relationships between the amount of body weight lost and the efficacy. And in fact, we do see among those who lose more weight, more improvement in quality of life, greater reduction in CRP. These are the relationships here for each 10% decrease in body weight. You can see about a 6-point improvement in KCCQ, 15-meter improvement in 6-minute walk, and about a 25% reduction in CRP. This is important because, as several of the speakers have already alluded to, we have even more potent incretin and other drugs that are coming down the pike that lead to much more dramatic weight loss than we observed in the STEP-HFpEF trial. STEP-HFpEF was then followed up, as I mentioned earlier, by a sister trial called STEP-HFpEF-DM. So this is the same trial design, but now it's in patients with HFpEF and type 2 diabetes, exactly the same findings. Improvement in KCCQ, reduction in body weight. The reduction in body weight was a little bit less, which is something that's been observed in people with diabetes. And this is data from the combined analysis, which published in the Lancet earlier this year. Now, this was not designed as an outcome trial. We never thought that we would see a significant reduction in outcomes with this small number of patients. But both individually within the two trials or in the combined analysis, there was a significant reduction, a non-pre-specified endpoint, mind you, but this is clinically adjudicated heart failure in the risk for heart failure worsening events with a hazard ratio of 0.27. So very low number of events, but certainly very interesting findings. And this has been followed up with a meta-analysis from both SELECT and FLOW, and also STEP-HFpEF. And you heard about the SELECT results in detail from Dr. Linkoff. We see, again, as you would predict here, very consistent across the studies, overall 31% reduction, and this is the heart failure events, 41% reduction. This is the individual trials here. You do see that the effect size visually is more striking in STEP-HFpEF, but the number of events is very low here, so the confidence bars are much wider. Looks like a little bit less of an effect in FLOW in a CKD population. Unclear what this means. This is a very high-risk group. But overall, it was a significant win for the composite of heart failure events or CV death or worsening heart failure events, but not CV death on its own. Now, there's another study that is coming soon, the SUMMIT trial. So Dr. Linkoff also measured tirzepatide, which is a combined GLP-1 receptor agonist and GIP agonist. And there has been a press release that this trial did meet its primary endpoint. Unlike STEP-HFpEF, this actually is a proper outcome trial. So the primary endpoint here is cardiovascular death or worsening heart failure. And this trial, which is not yet reported, according to the press release, did meet that endpoint. So these drugs seem to really work to help people with HFpEF. Why? Why does this happen? We've been very interested in this, and we've got some early evidence from this study of dapagliflozin. Now, dapagliflozin, an SGLT2 inhibitor, leads to much less weight loss than a GLP-1 RA or other incretins, but it does lead to significant weight loss, and you tend to see more weight loss in people with more severe obesity. So we tested the hemodynamic effects of treatment with dapagliflozin in a very small mechanistic randomized trial, 37 patients with HFpEF, 70% obese, and they all underwent invasive hemodynamic exercise testing, rest exercise assessments, blood and plasma volume, body composition, biomarker assessments at baseline. Then they were randomized double-blind to dapagliflozin or placebo, treated for 6 months, and they came back and they did it all over again. And we saw our primary endpoints of rest and exercise wedge pressure, left atrial pressure. Again, this is the most direct hemodynamic indicator of heart failure severity. A very significant 20% reduction in both rest and exercise wedge pressure with dapagliflozin as compared to placebo. So there are hemodynamic benefits. And why am I showing you this in a talk on obesity? The strongest correlate of the improvement in wedge pressure that we saw was the degree in change in body weight. Now, we also saw a significant reduction in plasma volume, and we know SGLT2 medicines are natriuretic, and we did see a minor reduction in plasma volume, but the hemodynamic improvement was much more strongly correlated with the change in body weight. as compared to the change in plasma volume. So supports this concept hypothesis that treating excess body weight can be really important. This is from a subsequent study where we looked at the patients who and quantified, okay, well, what was the weight that was lost? What were the characteristics of it? Again, measured directly by DEXA and blood and plasma volume. And you can see that the majority, at least with SGLT2 inhibitors, the majority of the fat or of the tissue lost was fat tissue. Only 15% was lean tissue, only 6% was plasma volume reduction. And when we looked at the specific fat depots, once again, we see it's more reduction in that android fat, upper body trunk fat, visceral fat, not so much in the fat-free mass. So we've really got to dial down more on this to better understand how this is important, but this is certainly very supportive because we know that the SGLT2 inhibitors also improve heart outcomes of CV death or heart failure hospitalization. Now, finally, we also know that patients with HFpEF frequently have hypertension, and even more frequently, they have a hypertensive response to exercise. So in addition to having stiff ventricles, they have very stiff aortas. And this leads to a marked hypertensive response to exercise. And in this study, we saw that this was very significantly attenuated with dapagliflozin, a 20 millimeter reduction in exercise blood pressure. This was not due to an effect on systemic vascular resistance. That was purely due to an improvement in arterial compliance. So this is arterial compliance at baseline. It goes down during exercise. This decline was abrogated with treatment with dapagliflozin. We also saw improvements in aortic input impedance, characteristic impedance. And we also saw reductions in stress blood volume. I showed you earlier that patients with this obesity phenotype have an increase in stress blood volume, poorer venous capacitance. Dapagliflozin was reducing that. Again, why am I showing you SGLT2 data? It's because the changes in arterial compliance and the changes in venous capacitance were very highly correlated with changes in body weight. So there's really something important about reduction in body weight and seeing hemodynamic benefits that we see that are very helpful for our people with HFpEF. So in conclusion, when you see patients with obesity and dyspnea, please, we all need to stop just ascribing their shortness of breath to being obese. This has really become the dominant risk factor for HFpEF in the United States. They frequently have normal levels of natriuretic peptides. We can't use these as rule-out tests. The pathophysiology is extremely complex. There is myocardial dysfunction, there's diastolic dysfunction, there's volume overload, there's inflammation, which is strongly tied to excess visceral fat. There's epicardial fat leading to epicardial extrinsic restraint on the heart, potentially paracrine effects on the heart. And most importantly, now we have new tools to treat this. From the STEP HFpEF program, we clearly see that semaglutide is effective to improve quality of life and exercise function. We do see evidence that there can also be improvement with reduction in heart failure events. A lot of these hemodynamic findings appear to be related to weight loss. The mechanisms are as yet totally unclear, but hemodynamics and loading conditions are certainly part of it. But we're really just scratching the surface, but it's a very exciting time to finally have some new treatments. So I'll stop there and thank you for your attention.
Thank you so much, Dr. Burlock. That was really interesting. And I wanted to start out with a question because you noted that that HFpEF is underdiagnosed, right? Because clinicians often will just attribute dyspnea and fatigue to obesity. But you also noted that the kinds of biomarkers they might order, like a BNP, might be normal. And I'd imagine even the echocardiogram, right? They're going to be looking for a reduction in ejection fraction, which may not be there. So my question to you is, what should primary care clinicians and other non-cardiologists, what can they do to determine which of their patients with these common symptoms could benefit from referral to a cardiologist?
That's a great question, and this is exactly what inspired us to develop and then validate the HFpEF score, the H2FPEF score. So we took a very large number of patients who had all undergone definitive hemodynamic testing, so we could define them as having not HFpEF or having HFpEF. And then we looked at all the predictors that discriminate these two. And it came down to age above 60, any history of AFib, BMI of 30 or greater, and treatment with 2 or more antihypertensives. So 4 clinical metrics, and then 2 echo, high EE prime, high RVSP. And the score ranges from 0 to 9. And if the score is 6, 7, 8, 9, it's 90%, 95% post-test probability, or pre-test probability if they have HFpEF. If the score is 0, it's very unlikely. If the score is 1, it's 20%. If it's in between, if it's 2 to 5, that's who you got to refer. But a lot of times people don't get echocardiograms, so we can't get the echo measures. So this led us to do a subsequent score called the ABA score, and this was just published in Nature Medicine like a month or 2 ago. This only uses 3 things: age, BMI, and history of AFib. And knowing those 3, you can plug those 3 variables into a logistic equation and estimate the probability that somebody with breathlessness has HFpEF. So if they have a high probability by that, that's somebody that you should refer to cardiology for consideration of HFpEF. So hopefully this will be used more frequently and we can detect more of these patients, because I think that HFpEF is egregiously underdiagnosed out there in the community, especially in obesity.
Thank you. And if you can, at some point, put links to those papers you just mentioned in the chat, I know people would appreciate it. I think we're going to do one more question and then we're going to break for lunch. And Dr. Khan, you were first up. Would you like to ask your question?
Sure. Really nice presentation. I think this follows the conversation for Mike's discussion. Is maybe some of the differences between the SELECT and STEP HFpEF correlation with weight loss is based on underlying pathophysiology. Do you think that so much more of that is due to obesity, and that's why there's a more direct link to that?
Yeah, I'm not. Can you ask that again, Sadiya? I was trying to kind of read your question at the time you were asking.
Oh, sure. Yeah, for like just the relationship between, or the causal role of obesity and HFpEF compared to obesity and ASCVD. Maybe that's why we're seeing differences in the signal between how dependent the effect is on weight loss between SELECT and STEP HFpEF. I just wonder if, if there's an outsized burden of obesity, then the benefit is more directly less.
Yeah, that's a really good question. That really gets at a crucial question, actually. And I think there can be, obesity does so many things. Excess body fat does so many things, and the amount of plasma volume expansion, the amount of inflammation, things like that, the amount of arterial stiffening and venous capacitance, that is all more linearly related to the amount of excess body fat. But there may also be things that are more just categorically sort of yes/no related to excess body fat that doesn't have as much of that kind of linear relationship. And those might be the things that go into MACE outcomes potentially. I'm just guessing. I actually asked Mike this in the question, like, why is there not this sort of evidence of a dose response for the MACE outcomes, but there is for other things like we saw with KCCQ score or 6-minute walk? I think it's a really good question, and I think it gets at the how complex the relationship is between excess body fat and heart failure versus like atherosclerotic cardiovascular disease. I think they might be a little bit different.
Great. Well, thank you so much. We do have more questions in the chat, and I hope we can get to some of these questions at this afternoon's panel discussion. We're now going to break for lunch, and we will reconvene at 1 o'clock. Thanks to all our morning speakers. Okay, good afternoon, everyone, and welcome to the afternoon session of today's Obesity Research Task Force Symposium on Obesity and Heart Disease. Someone did ask earlier about whether the video would be available, and it will. It will be posted both on the NIDDK website as well as the NIH Obesity Research Task Force website. And Ms. Janaya Peters, who works with our contractor, says that she will send out a link to the video recording as soon as it's available to all of the registrants. So I just wanted to clarify that. And I'm now going to turn it over to Dr. Sharoma, who will do the introductions this afternoon.
Well, welcome back, everyone. Hopefully everybody got at least a couple minutes away from their desk. It's my pleasure to introduce Dr. Imo Ebong. Dr. Imo Ebong is a heart failure cardiologist and physician scientist who provides care for patients with heart failure and cardiomyopathies of various etiologies, including during pregnancy. She performs both epidemiological and clinical research that is focused on heart failure and its risk factors in women during pregnancy and the postmenopausal period. Dr. Ebong's talk today is titled "The Role of Obesity on Cardiovascular Disease Risk in Pregnant and Postmenopausal Women." Welcome, Dr. Ebong.
Thank you so much, Eric, for that generous introduction and the honor of presenting among such a distinguished panel of speakers. I will be discussing the role of obesity on cardiovascular disease in women. I have no relevant disclosures. My objectives are: one, to discuss the prevalence of obesity and its relationship to cardiovascular disease in women, and two, to discuss the pathophysiological mechanisms that link obesity with specific cardiovascular disorders in pregnancy and postmenopausal women. Although most women don't know it, cardiovascular disease is a major cause of morbidity and mortality amongst women. As alluded to by Dr. Bullock, especially in reference to heart failure with preserved ejection fraction, women are at higher risk of cardiovascular disease when they are insulin resistant or have excess fat mass. Additionally, women are disproportionately affected by the obesity epidemic and are expected or estimated to have a prevalence of obesity as high as 21% in 2025, when compared to only 18% in men. As Dr. Khan discussed in her presentation, obesity affects women of all age groups with similar prevalence and begins even before adulthood. Additionally, women have a higher prevalence of severe obesity than men, especially among those who are aged 40 to 59 years. But there are racial and ethnic differences because the prevalence of obesity and severe obesity is higher among non-Hispanic Black women when compared to other races, as well as the Hispanic ethnicity. And African American women in particular have a higher obesity to cardiovascular disease association. Obesity increases the risk of several traditional cardiovascular disease risk factors, such as hypertension, dyslipidemia, and type 2 diabetes, as well as the risk of sex-specific risk factors such as gestational diabetes, preeclampsia, and premature delivery. Obesity also increases the risk of cardiovascular diseases such as peripheral artery disease, heart failure with preserved ejection fraction, ischemic heart disease, ischemic stroke, and obstructive sleep apnea. But for the purposes of my talk, I will be focused on hypertensive disorders as well as heart failure, and particularly hone onto mechanisms that are more prevalent and important in women. In the Cardiovascular Disease Lifetime Pooling Project, which collected individual-level data across several population cohorts in the United States over the last 7 decades, it was demonstrated that as obesity worsened, the cumulative incidence of cardiovascular disease increased among women and was highest among those who have severe obesity. Additionally, the adjusted hazards of experiencing a heart failure event, fatal and non-fatal MI or cardiovascular disease event was highest among those who had a body mass index that was greater than or equal to 40 kilograms per meter squared. Also, when compared to a non-cardiovascular death, the adjusted hazard ratio of experiencing a cardiovascular event was double amongst women, amongst obese women. Hypertensive disorders affect 8 to 10% of pregnancies and increase with rising maternal age, being most common amongst women that are older than 35 years of age. Maternal obesity also increases with maternal age and is strongest in that same age group, 35 years, particularly amongst those who have low socioeconomic status. Obesity increases the risk of all forms of hypertensive disorders of pregnancy amongst women, such as gestational hypertension, chronic hypertension of pregnancy, preeclampsia, and superimposed preeclampsia, thereby predisposing to adverse pregnancy outcomes. But beyond pregnancy, obesity also increases the lifetime risk of hypertension amongst women. On their part, hypertensive disorders of pregnancy increase the risk of short-term and long-term heart failure. For instance, peripartum cardiomyopathy is 13 times more common amongst women with hypertensive disorders of pregnancy. Heart failure with preserved ejection fraction is 10 to 42 times more likely among women with chronic hypertension and 3 to 31 times more common amongst women with gestational hypertension or preeclampsia. Additionally, these hypertensive disorders of pregnancy are associated with a fourfold increase in the risk of heart failure in later life. The risk of heart failure also rises with maternal age as shown and is most prevalent in the same age group, women that are greater than 35 years of age. The mechanisms through which obesity increases hypertension and heart failure risk in pregnant women, which we'll be discussing in subsequent slides, include increases in leptin secretion, aldosterone and mineralocorticoid receptor activation, sex hormone alterations, and aberrant estrogen signaling, endothelial dysfunction, as well as insulin resistance. One of the mechanisms by which obesity increases hypertensive disorders of pregnancy, which was discussed extensively by Dr. Scherer, involves increases in the fat-secreted hormone leptin. But this risk of hypertensive disorders such as preeclampsia amongst pregnant women actually begins prior to gestation. Pre-pregnancy obesity increases leptin secretion, which stimulates endothelial dysfunction, which is a potent risk factor for placental ischemia. And pregnant women that are obese experience significant increases in leptin secretion in early pregnancy. By mid-gestation, placental ischemia further stimulates leptin secretion, which worsens endothelial dysfunction. And by late gestation, both endothelial dysfunction and placental ischemia overwhelms the oxygen and nutrient needs of the fetal-placental unit, thereby predisposing to the development of preeclampsia. The menopausal transition is also associated with adverse changes in body composition, which begins with a significant increase in the fat mass that occurs as early as 2 years before and persists up to 1.5 years after the final menstrual period. For the average woman, this will result in an increase in body fat mass, a significant increase and near doubling of the rate of gain of body fat mass from about 1 gram per year to 1.7 grams per year. And this leads to a significant increase of about 6% in fat mass over the 3.5 menopausal, over a 3.5 year menopausal transition period. On the other hand, as shown in the figure, you can see that the proportion of lean mass decreases across the menopausal transition by approximately 0.5%. But fat mass accumulation could vary across menopausal age categories and may vary for generalized fat mass as well as regional fat distribution. So this was a study that we conducted in the multi-ethnic study of atherosclerosis, and it involved 746 2,436 postmenopausal women. Just to provide context, we categorize the women as having early menopause if they experience menopause before 45 years of age, and late menopause if they experience menopause at greater than or equal to 55 years. Women that experience menopause between 50 to 54 years of age were used as the reference group, because that's the average age of menopause in the United States currently is about 50 to 51 years. And we found that women that had late menopause or late menopause was associated with significantly associated with measures of central adiposity such as waist circumference, waist hip ratio, and waist height ratio. So you can see that the increase in waist circumference was about 2.28 centimeters above women in the reference group. Waist hip ratio, that's a ratio, was 0.013, and waist height ratio was 0.014. However, late menopause was not significantly associated with body mass index. This is important. The pathways that are shown here just is an illustration of the complex links between obesity, endothelial dysfunction, and cardiovascular disease after menopause. Adiposity stimulates inflammation, which is a risk factor for coronary artery disease and heart failure. But adiposity also increases the risk of insulin resistance and sympathetic nervous system hyperactivity, as well as sex hormone alterations, which promote androgenicity. Collectively, androgenicity, insulin resistance, and sympathetic nervous system hyperactivity promotes endothelial dysfunction, which is a risk factor for coronary artery disease and heart failure. This is another study that we performed in the atherosclerosis risk in community studies. It involved 4,441 postmenopausal women that were followed for a mean period of about 16.5 years. We found that both overweight and obesity increase the risk of heart failure across all menopausal categories that we earlier described. Central obesity also increased the risk of heart failure amongst all menopausal age categories. While the overall risk of heart failure was highest amongst women with late menopause, we can see that the attributable risk of both obesity and overweight was highest amongst women that experienced late menopause. Also, in a very similar pattern, the attributable risk of central obesity on incident heart failure was also highest amongst women that experienced late menopause. In regression analysis, we showed that a standard deviation increase in body mass index, which was an indicator of generalized adiposity, was associated with doubling of the risk of incident heart failure in postmenopausal women, while a standard deviation increase in waist circumference was associated with almost tripling of the risk of incident heart failure amongst postmenopausal women, suggesting that while obesity may be important across women of all menopausal age categories, it was particularly deleterious for women that had experienced menopause more than or at 55 years of age. In this other study, which we actually conducted, this was in the multi-ethnic study of atherosclerosis. It involved 3,599 postmenopausal women that had been followed for 7.6 years of follow-up. We investigated the influence of obesity-related conditions such as hypertension, hypercholesterolemia, dysglycemia, inflammation, which we indicated by interleukin-6, on the relationship between both generalized as well as central obesity and heart failure. We found that while in minimally adjusted and unadjusted models, that's model 1 and 2, obesity was significantly associated with an incident heart failure. But when we adjusted for the obesity-related conditions that I earlier mentioned, these associations were significantly attenuated and nullified almost completely in in the final models, model 4, where we replaced left ventricular mass hypertrophy or by EKG with left ventricular mass by M, suggesting that while both generalized and central adiposity increase the risk of heart failure, these associations were largely driven by obesity-related conditions, meaning that even though we should focus on obesity, we should also focus on diabetes, hypertension, inflammation, etc., these conditions that are being driven by obesity. As shown here in this Kaplan-Meier curves, we can see that the probability of being free from incident heart failure at the end of follow-up was significantly lower amongst women with severe obesity. That's the last group here, as well as amongst women that had central obesity. And in the multi-ethnic study of atherosclerosis, we further went on to explore the relationship between adipokines, which are fat-secreted hormones that we have heard a lot about so far today, and heart failure in about 746 postmenopausal women who had a median follow-up of 17.8 years in the multi-ethnic study of atherosclerosis. And for this study, we measured adiposity by visceral adipose tissue obtained from abdominal CT scans. And as you know, this is a more sensitive way of estimating adiposity. We found that a standard deviation increase in adiponectin was associated with 150% increase in the risk of heart failure among women, postmenopausal women, while a standard deviation increase in resistin was associated with a 50% increase in the risk of heart failure in postmenopausal women. There were no significant associations with leptin. But what perhaps intrigued us or surprised us most about this result is that we wondered, how could adiponectin, which is supposed to be the good fat hormone, right, and is anti-inflammatory, increase the risk of incident heart failure? Well, adiponectin, secretion of adiponectin is stimulated by natriuretic peptides, which we know are well-known potent biomarkers of heart failure incidence and prognosis. And natriuretic peptides by themselves, their secretion is also influenced by fat mass. Stay tuned for more on that. Sex hormones are also related with adiposity in postmenopausal women. The onset of menopause is associated with decreases in ovarian estradiol production, which promotes obesity. And dehydroepiandrosterone, predominantly secreted from the adrenal gland, becomes the major source of sex hormones in postmenopausal women and undergoes conversion in peripheral tissues, mostly adipocytes, under the effect of local tissue aromatase into cell-specific estrogens as well as testosterones. Overall, there's a net loss in the cardioprotective effects of estradiol due to increases in sympathetic drive as well as loss of the anti-obesity effects of estradiol. Testosterone, also produced by the same process, promotes visceral adiposity. But perhaps what is important is not the actual levels of the hormones, estrogen or testosterone themselves, but what we define as relative androgenicity, which is the ratio of testosterone to estradiol ratio. This relative androgenicity has been shown to increase with fat mass and is associated with greater hypertension and heart failure risk, as has been demonstrated in the multi-ethnic study of atherosclerosis. Why is this important? Well, epidemiological studies from the study of women's health across the nation have shown that more body weight and abdominal fat predicted higher androgen levels during menopause. And androgenicity has been linked to adverse cardiovascular profiles in prior studies. most importantly, the influence of obesity, which is the focus of our discussion today on androgenicity and cardiovascular disease, increases with body fat. Again, illustrating that, excess adiposity is a significant risk factor for cardiovascular disease amongst women. And Dr. Bullock did an excellent presentation on heart failure with preserved ejection fraction, highlighting sex differences and differences in men and women. But obesity, I want to stress further that obesity acts synergistically with estrogen deficiency in postmenopausal women to increase the risk of heart failure with preserved ejection fraction. Obesity depletes natriuretic peptides, and this downregulates the production of particulate granulate cyclase. In postmenopausal women, both estrogen deficiency as well as obesity decreases nitric oxide levels, and this also depletes soluble granulate cyclase levels. So depleted levels of both particulate and soluble granulate cyclase inhibits the cyclic GMP protein kinase G pathway, and this has adverse effects on myocardial relaxation, endothelial function, arterial compliance, adipogenesis, and fibrosis, leading to increased risk of heart failure with preserved ejection fraction. How about endothelial dysfunction? In postmenopausal women, both aging as well as estrogen deficiency increases fat mass, as we mentioned earlier. Obesity then will promote endothelial dysfunction through indirect mechanisms, which include insulin resistance, sympathetic nervous hyperactivity, decreased estrogen receptor sensitivity, as well as direct mechanisms that include the production of pro-inflammatory adipokines, generation of reactive oxygen species, as well as elevations in free fatty acid levels. Collectively, these mechanisms will decrease nitric oxide bioavailability by either reducing its synthesis or increasing its inactivation, thereby promoting endothelial dysfunction. How is the sympathetic nervous system involved? By driving the release of inflammatory cytokines, causing leptin hypersecretion, insulin resistance, and upregulating the renin-angiotensin-aldosterone pathway. Obesity will enhance the secretion of aldosterone, as well as enhancement of mineralocorticoid receptor activity. This causes sympathoexcitatory effects, which are partly suppressed or muted by the effects of estrogen in premenopausal women. But aging increases sympathetic nervous activity more in women than men, especially after menopause. And this is partly due to the loss of the sympathoinhibitory effects of estrogen. So endothelial dysfunction and hypertension are both strongly linked to activation of the sympathetic nervous system in postmenopausal women. There are several areas of possible future study that comes to my mind. One, is there a role for adipocyte-secreted hormones like the ones we've mentioned beyond traditional risk markers such as natriuretic peptides as indicators of cardiovascular and heart failure risk amongst women? Two, beyond weight reduction, are there any other benefits of targeting obesity-driven in pathways such as inflammation for the reduction of cardiovascular disease and heart failure amongst women? Should we consider sex hormones and reproductive status, such as menopausal age, which is not something that we routinely screen for on clinical assessment when assessing the risk and treatments of cardiovascular disease and heart failure? in obese women. I will conclude by saying that obesity causes sex-specific risk factors for cardiovascular disease in women through mechanisms that are unique to their hormonal and reproductive status. Also, obesity is a major modifiable risk factor that can be targeted to decrease the risk of cardiovascular disease across all life stages amongst women. Thank you for your time.
Thank you so much, Dr. Ebong, for that really excellent talk. I see we have several questions in the chat. We'll have time for maybe 2 or 3 of them. And Dr. Borlaug, I see you were first up. Would you like to ask your question?
Sure. First, great talk, Emo. Thank you very much. I was thinking about the hypertensive disorders of pregnancy, and I think some people kind of think that this is a risk factor because of the pregnancy, but maybe it's just that the patient is a vulnerable patient, has more vascular stiffness and ventricular stiffness and all of this, and the pregnancy is the stress test, basically, the hemodynamic stress test that's bringing it out. And should we treat those patients more aggressively? And obviously you'd like to test that in a trial, but it would have to be an enormous trial and no one would fund it. So what should we do? Should we be treating those people more proactively, those women?
Thank you so much, Dr. Borlaug. I completely agree with you. I think that we should treat these people more aggressively. If we fail to acknowledge reproductive risk factors while assessing women for cardiovascular disease, I think we have missed the mark. Like you said, some of the factors that stimulate ovarian aging and cause menopause, particularly early menopause, has shown you those women have the highest risk of heart failure. Some of those same factors also stimulate cardiovascular aging. So you have to target them. You have to target those risk factors. And obesity is important for all women, irrespective of when they experience menopause, during pregnancy, after pregnancy. But perhaps, what these epidemiological studies have shown us is that for women who experience late menopause, obesity is particularly important. So perhaps we should be more aggressive amongst those group of women.
Great,
Could I just ask one more quick one about
Sure.
body composition changes at the menopause transition? Because that was the other thing that I was really thinking about with your age of menopause and the obesity. How do you think all that factors in?
Yeah, so the relationship between menopause and adiposity is really complex. While women that are underweight experience menopause before women that are overweight or obese, after menopause or just before the final menstrual period, there's a significant increase in body fat mass. And this starts from 2 years before and extends as much as 1.5 years after the final menstrual period. And so after menopause, then women start gaining weight, etc. So, and the body composition, as you mentioned, I'm glad you brought it up, may differ from generalized versus abdominal obesity. Abdominal obesity seems to be the bigger trigger factor, even more than generalized obesity from all that. But yes, menopause, the relationship is extremely complex, but menopause does affect body composition by causing increases that begin before and persist at least 1.5 years later.
And that ties in with a question from Susan Freed. So if you have lower body adiposity, does that attenuate the risk of heart failure in women?
Yeah, as shown, yes. As shown in for heart failure, yes, in the studies that we demonstrated, lower body adiposity, women that had both generalized or central obesity had higher risk of heart failure, whether you were measuring it by, BMI as well as waist circumference, and that risk was higher amongst those with late menopause. And in the other study that we demonstrated in the MESA study, we found out that late menopause was actually associated more strongly with multiple measures, irrespective of how you were measuring them, of central adiposity than generalized adiposity. Yes, so lower adiposity, whether generalized central is better, women with higher have increased risk of heart failure.
Thank you. And one last question, Lori Donzi has an interesting question. Lori, do you want to unmute yourself?
Sure. So, I was surprised that the women with later menopause had, higher central adiposity and, the cardiovascular risk. So I was wondering if you had any thoughts about why that is, because I was thinking, if their estrogen stays more years, I would think it would be protective.
Yeah, I think that's driven by androgenicity.
Mm-hmm.
And that's the concept that we're seeing, that is not merely the level of the hormones themselves when you're thinking in isolation about either estrogen or testosterone. Is actually the ratio of both the testosterone to the estrogen. So when women get to menopause, the ovaries stop producing estrogens, which is the cardioprotective hormones, and most of their sex hormones now comes from the dehydroepiandrosterone produced from the adrenal glands. And this is converted peripherally into specific testosterone. We don't know, how the concentrations of testosterone versus estrogen production are regulated, but it seems to be more towards androgenicity, relative androgenicity. So, even though that peripheral adipose tissue is where the conversion of the DHEA takes place. So that's where you get your sex hormones. It's from the adipocytes, the majority of it. But perhaps what is more important is that, it tends to produce more of testosterone to estrogen and leads to relative androgenicity. I think the important thing is not just the levels of the hormones themselves, but the ratio, or what we call relative androgenicity.
Yeah.
Great. Thank you so much. And I'm now going to turn things over to Dr. Sharoma, who will introduce our final speaker of today.
Great. Dr. Tiffany Powell-Wiley is an Earl Stadman investigator and chief of the Social Determinants of Obesity and Cardiovascular Risk Laboratory at the National Institute of Health, with a joint appointment in the cardiovascular branch of the Division of Intramural Research at the NHLBI and the National Institute on Minority Health and Health Disparities. Dr. Powell-Wiley's interdisciplinary team uses community-engaged research, epidemiological methods, and translational approaches to better understand the social factors that promote obesity and limit cardiovascular health. In 2021, Dr. Powell-Wiley received the American Heart Association's Population Research Prize, and in 2023, she was chosen for the American Society of Clinical Investigation. Prior to joining us here at the NIH, Dr. Powell-Wiley completed an internal medicine residency at Brigham and Women's Hospital up in Boston and a cardiology fellowship at the University of Texas Southwestern Medical Center, where she served as the Cardiology Division's first chief fellow. Dr. Powell-Wiley's talk this afternoon is titled Promoting Health Equity for Patients with Obesity and Cardiovascular Disease. Thank you for being here this afternoon.
All right. Thank you so much, Dr. Sharoma, and thank you all for the opportunity to speak today and talk about where we are in terms of health disparities and health equity, particularly as it relates to patients with cardiovascular disease. So we know from data from the National Health and Nutrition Examination Survey, or NHANES, that obesity prevalence has increased over the past several decades. And most recent data shows obesity, and particularly class 3 obesity or severe obesity, increasing across all racial and ethnic groups, except for stagnant rates in non-Hispanic Black men since 2005 and 2006. And we've seen more rapid increases of particularly in Hispanic populations in the United States. And so it relates to what we see in terms of disparities in cardiovascular outcomes. We've also seen from data projecting where the obesity epidemic is going, that projecting until the year 2050, we will see more significant increases, projected increases across populations in terms of obesity prevalence. And this will contribute to significant increases in cardiovascular disease prevalence, particularly in the United States. It will also relate and increase healthcare costs within the United States related to treatment, not only of risk factors, but of cardiovascular disease, where we're projected to see increases of up to 3 times increases in healthcare costs for treating obesity and other risk factors, and quadrupling of healthcare costs related to cardiovascular disease. And this is if we aren't changing the trajectory of obesity prevalence and how we intervene on the obesity epidemic in the US. Across the globe, we're also projected to have increases in prevalence, especially when we look across countries, when we think about what are differences between countries based on socioeconomic level. And so when we look at income groups based on the World Health Organization, we see that across all populations, across all income groups, it's projected that overweight and obesity prevalence will increase up until 2035. But what is important to recognize that for low income, low and middle and upper middle income countries, it's projected that they'll see the greatest increases in overweight and obesity prevalence based on data from the World Obesity Federation. And so this highlights the need for interventions or policies focused on how we can address the obesity epidemic, particularly in low and middle income countries. And this shift in obesity prevalence, particularly in low and middle income countries, fits with what is projected based on the global burden of disease studies that show how cardiovascular disease prevalence will increase in those low and middle income countries around the world. And so when we think about obesity and how it relates to cardiovascular disease, we can think of it in relation to the first stage as a part of the continuum of cardiovascular kidney-metabolic syndrome, and how excess or dysfunctional adiposity leads to the development not only of hypertension, diabetes, and hypercholesterolemia, but also to factors related to kidney disease and ultimately to heart failure and cardiovascular disease, as has been discussed so eloquently today. And so treatment of obesity, and particularly treatment for those who are most at risk for obesity, is really the first stage at addressing cardiovascular kidney metabolic health. And when thinking about this framework of cardiovascular kidney metabolic health that was, and the syndrome that was put forward recently by the American Heart Association, it's also important to consider the social determinants of health that are influencing each level of care for those with CKM syndrome, and how these social determinants of health are important in considering screening, risk prediction of CKM syndrome, but also in how we compose and design the clinical care teams and implement care for those with obesity and cardiovascular kidney metabolic sequelae related to obesity. And so in our statement that we put forward about the connections between obesity and cardiovascular disease, we highlighted how biology interacts with these psychosocial, socioeconomic, and environmental factors, or what we can term the social determinants of health, that contribute to worsening outcomes related to obesity. And just to give you a sense of what these social determinants are and how they connect to the development of cardiovascular disease, we know that there are structural factors related to socio-political and economic contexts that influence access to education and income, but also that influence the neighborhood environment in which individuals live. And these social and structural factors influence more intermediary determinants of health, including the social and community context in which individuals live, their perceptions around their environment, but also the social risks that they are experiencing related to social needs, such as food insecurity, housing, transportation, and financial strains. And ultimately, those influence their lived experiences, which are define their social position within a community. And these are the stressors that have actual biological sequelae that lead to the development of cardiovascular disease. And so in thinking about better understanding the role of social determinants in the development of obesity and cardiovascular disease, we need more work in understanding what are some of these biological pathways that are influenced by social determinants that determine the development not only of obesity, but the cardiovascular consequences of obesity. And we have some data to show that these social determinants influence the levels of stress hormones, whether it be levels of cortisol, but also they influence norepinephrine, epinephrine that can have direct effects not only on immune cells and immune cell function, but also on the composition and the immune cells that are embedded in adipose tissue and influence the function of adipose tissue. These social determinants and these stressors also have direct influences on levels of adipokines that influence inflammation, insulin resistance, and ultimately the cardiovascular risk for individuals. And so understanding these biological pathways can give us a sense of not only what are some of the pathways leading to the development of cardiovascular disease, but also what are some of these pathways that may be important in determining the efficacy of treatments for obesity and cardiovascular disease. And so, of course, and it has been talked about today, we know that recent trials highlight the importance of the newer agents in pharmacotherapy for risk reduction for cardiovascular kidney metabolic syndrome. As mentioned, SELECT trial, the STEP 8 HFpEF trial, and the FLOW trial have all provided evidence for the treatment of individuals with cardiovascular disease and obesity, as well as the treatment of individuals with kidney disease and obesity using GLP-1 receptor agonists. Now we're waiting for results from additional trials that including SUMMIT and SURPASS CVOT, which will give us insights into the role of these GLP-1 receptor agonists into additional populations with cardiometabolic and kidney syndrome. And so these trials highlight that these are important agents for the treatment of populations with obesity and cardiovascular disease. But the questions that we need to answer are what are the efficacy of these treatments, particularly of GLP-1 receptor agonists across sex groups, but also across diverse racial and ethnic populations. We need additional data, post hoc data, to tell us, are these medications as efficacious as or do they have similar efficacy across racial and ethnic populations? We also need to understand what are some of the social factors that may limit the efficacy for populations that are most affected by adverse social determinants. And then most importantly, for patients who qualify and require treatment with obesity pharmacotherapy, how do we lower the barriers to treatment and for these patients? And how do they get access to these medications? And so again, ultimately, how do we focus on health equity and accessibility in the treatment of obesity for patients who are in most need? And so we know that weight bias and weight stigma within the clinical care system can have an effect on not only whether patients are seen by clinicians, but also can limit referral for treatment for obesity, not only pharmacotherapy, but treatment across the spectrum of agents and treatments for obesity. And it also places unnecessary burdens on accessing treatments for patients. There's also limited insurance coverage for pharmacotherapies, including the GLP-1 receptor agonists. And there's also limited access to specialists, including obesity medicine specialists, particularly those who may have backgrounds also in cardiology subspecialty training that can help in caring for patients who have not only obesity, but cardiovascular and kidney sequelae. And finally, there's been limited referral rates for bariatric surgery for patients who are at highest risk for obesity, particularly from racial and ethnic minoritized populations. And ultimately, for patients with obesity and cardiovascular disease, care can become fragmented and difficult to navigate because of the multiple subspecialists who may become involved in care and the hurdles that are required for gaining treatment and gaining medications. And so in thinking about how do we reduce these barriers, we need to move towards and think about how do we move towards a more patient-centered treatment model where obesity education for clinicians highlights the importance of obesity as a disease and the complexity of obesity, and in order to try to reduce weight stigma and bias. We need to better understand the composition and how interdisciplinary care teams can work for the treatment of cardiovascular kidney metabolic syndrome. In particular, how can we address social needs as a part of these care teams to reduce barriers to treatment. We know from data from the Medicaid expansion that can increase health insurance access to referrals for treatments such as bariatric surgery. But we need to think about what are some of the targeted interventions that can help increase referrals for particularly Black and Hispanic populations, again, who are at increased risk for obesity and cardiovascular disease. And then we have digital health technology, including telemedicine, that can work to connect providers in obesity medicine to those patients who may not have direct access or may have difficulty getting to the clinical setting. And these are tools that need to be studied further. In terms of digital health tools, we have important data that tells us that tools such as smart scales for self-monitoring, digital apps for monitoring dietary intake and physical activity can improve weight loss outcomes. However, we still need more data on how these tools can be utilized in diverse populations who may have barriers to accessing not only digital health tools, but also even accessing broadband to utilize such tools, and how these interventions might work in diverse populations. These trials, such as the SELECT trial, as well as STEP HFpEF and the FLOW trial, give us important data on pharmacotherapy, but we also know that we have data from recent trials that tell us other treatments along the continuum are efficacious for populations who are at high risk for obesity, but may not have been traditionally included in clinical trials. We know, for instance, from the PROPEL study that in primary care settings in Louisiana, that utilizing an intervention which involved intensive lifestyle interventions in clinics in low resource populations, that it could lead to clinically significant weight loss for those populations, and that data looking at Medicare data has shown that bariatric surgery can be effective in Medicare populations and appears to potentially lower all-cause mortality, but also in particular lower the risk for heart failure, myocardial infarction, and stroke. And so these analyses suggest that there is benefit in referring patients over the age of 65 for bariatric surgery, but also thinking about how do we get underserved populations access to lifestyle interventions for the treatment of obesity. Recent data from Propel also gives us a sense of what may be predictors of the differences across racial and ethnic groups and weight loss with especially this behavioral intervention targeting and tailored for a low resource population. Prior studies have shown quite a bit of data to show that lifestyle interventions, but also bariatric surgery, have lower effectiveness in terms of weight loss among racial and ethnic minoritized populations. But this data from Propel shows us that less self-monitoring and especially less engagement with the Propel intervention were predictors of the racial differences in weight loss in the Propel population, where African Americans in the population had lower levels of weight loss. And so there needs to be more understanding of the predictors of engagement, particularly in behavioral interventions among African Americans, but across, again, populations underrepresented in clinical trials. And then if we think more broadly, we need to be mindful that the medications, the pharmaceuticals, and therapeutics for obesity need to be considered in the context of also addressing the systems, both at the individual, but also at community and environmental levels that influence the global obesity epidemic. If we take this systems perspective, we want to think about interventions that are multi-level, that account for not only the changing and improving individual level health, but also changing the environment in which they live and how and what the resources around a healthy lifestyle are available for improving cardiometabolic health. And ultimately, we can think of community engagement in the design of these interventions to design them based on the needs of the specific communities who are most affected by adverse social conditions. There are data to support these types of interventions. Particularly, we have housing interventions that have been shown to improve and reduce the rates of obesity for those moving to areas with higher levels of socioeconomic status by utilizing vouchers to move to those communities. We have data that show that built environment changes with increasing access to public transportation can reduce obesity. More recent data shows that nutrition interventions that provide produce prescriptions can lower body mass index and improve cardiovascular risk. And then we know that community engaged interventions that are designed in concert with community members, particularly working with community advisory boards, can reduce the prevalence not only of childhood obesity, but can improve cardiovascular health for adults. And so these are the types of interventions that can be leveraged in conjunction with treatments like the GLP-1 receptor agonists. More broadly, when we think of an equity-focused obesity treatment, we need to think of policy-level interventions that address the socioeconomic and environmental drivers of obesity and how those can be incorporated with the treatments within the clinical setting. So questions that we need to consider, again, are how can medical education address weight stigma and bias? What are policies that may work in expanding access to treatments across the continuum, including lifestyle interventions, but also medications and bariatric surgery? And then what does the composition of these interdisciplinary teams need to look like for coordinating care for patients with obesity and cardiovascular kidney metabolic syndromes? And how do we address social needs within those teams? Ultimately, how do we implement these tools around social determinant screening as a part of the care for CKM syndrome? And so I would argue that we need to think of screening just as we think of the stages of CKM syndrome across the life course. We need to think of social determinant screening across these stages. And so when these social needs that we need to address, whether they be food insecurity or housing or financial factors, these are social determinants that can be assessed within the clinical workflow. They can be assessed through working with community health workers and care navigators that can be integrated into a care team with the goal of helping patients to not only access the resources for these social needs, but also to navigate the healthcare system and to manage utilization of these resources. And ultimately, it can involve leveraging existing community resources and community programs where healthcare systems understand, but also advocate for specific, the development of specific resources to address the needs of their patient populations. We have tools that are available for screening these social determinants and social need factors, including the Health Leads tool, but also tools developed by CMS and the Academy of Family Physicians, as well as the OCHIN and Prepare tools. And the Health Leads tool has been shown when utilized in the healthcare setting, it can improve blood pressure and cholesterol levels by connecting patients to resources around social needs. There's been data to look at how hospitals and healthcare systems are utilizing social needs screening to date, and well over 70% of hospitals in the United States are screening for at least one health-related social need, with about 60% screening, not only screening, but providing strategies for addressing at least one social need. And value-based care programs are more likely to be those that are screening and participating and partnering with community-based organizations to provide resources around social needs. But the questions become, which are the social needs that are most critical within a healthcare system that need to be addressed to improve obesity rates, but also to improve cardiovascular risk? And then how do we, and to what extent do healthcare systems need to partner with community-based organizations to resolve these social needs and to improve health for their populations? We need much more data to show us what types of systems work within the healthcare organizations. And so the critical questions that I would leave you with today in terms of what to consider in addressing health equity in obesity and cardiovascular kidney metabolic health is, what are policies or interventions that can expand access to obesity treatments across the continuum for the populations that are underrepresented and minoritized, particularly in the US? Then how do we better understand how social factors impact the efficacy of obesity treatments, especially these newer pharmacotherapies in diverse populations? Are there biological pathways related to chronic stress and inflammation that limit the efficacy of pharmacotherapy? And then what are adjunctive therapies or interventions that are needed with pharmacotherapy that can lead not only to weight loss, but weight loss maintenance for diverse populations? Ultimately, these treatments show great promise for cardiovascular kidney metabolic syndrome. And as I mentioned, we have data that shows the differential efficacy, not only of lifestyle interventions, but also of other treatments for obesity in underrepresented populations. And so we need more data to tell us, what does the efficacy of these new medications look like for underrepresented populations? And if we're going to address the limited access and availability of these treatments, we need studies on efficacy, as well as access and addressing social needs that limit availability of treatments for underrepresented and minoritized populations. So thank you, and happy to take questions.
Great. Thank you so much, Dr. Powell-Wiley, for that was an excellent and really comprehensive talk on a really critical area in obesity research. And I think we have time for one question from our audience. And the question is, are medications a sustainable model for obesity treatment and CVD reduction? And do lifestyle and behavioral interventions have a role also in at-risk populations?
So I would, we need more data, I would say, in understanding what the role is in combining lifestyle interventions with obesity pharmacotherapy. We have some data to suggest that combining these medications with physical activity, for instance, or physical activity interventions may improve weight loss maintenance, but these are preliminary studies that have not been done in diverse populations. And so there's much more room to understand what those combined therapies would look like and how would they work, especially for patients who may have limited access based on financial reasons, based on insurance status. And so what do those additional treatments with lifestyle, with diet, what do those look like?
Thanks again. And I want to thank all of our speakers today. It's been an absolutely wonderful series of presentations. I've learned so much. And we now are going to move into our panel discussion where you get a chance to ask all of those questions we didn't have time for before. And this is going to be moderated by Dr. Eric Sharoma. Eric?
Good afternoon. Thank you all for your great attention and questions. I think it really complemented and helped with the day. As we get set up, I'd like to invite our speakers to go ahead and turn on their camera if they're able, and our hosts if they wish to ask more questions. And I realized after introducing everybody else that I actually did not introduce myself at all today. So for those who don't know me yet, I'm Eric Sharoma. I'm a program director at the NHLBI, and my background is in epidemiology and exercise physiology. So you'll see that some of my questions spin in that direction. One of my favorite things about these panels is that we can look at some of the cross-cutting themes and questions across all of these speakers. So we'll be trying to focus on some of those that can really engage a discussion across multiple speakers. One of the benefits to moderating these is that I get to ask the first question. So as somebody with more of an epidemiology background, I often focused on population level research and interventions. However, with these drugs and a lot of the other anti-obesity treatments coming up, I thought it'd be interesting to think about the heterogeneity of obesity or the variability in responses that we've seen to some of these things. So for example, in the fit versus fat debate, or what are we doing when we're kind of just summing a lot of the population effects, knowing that we have lower non-responders. So how are you thinking about some of this in some of your research or in clinical care? And then also, how do we see this differing by different life stage or different times where we may be able to do some of this? And I'm going to ask for volunteer rather than calling on people. And please, for the audience, put your questions and or themes in the chat, and I'll see how many we can get to. Any brave volunteers?
I will volunteer, Eric. Thank you for that. That was quite a multi-part or multi-component question, though, so I'll try to answer at least one component of it. I think the heterogeneity of effect is a really important aspect of this conversation, and especially in the real world. And I think Dr. Powell-Wiley gave a really nice overview of what are the outstanding questions. We have exceptional and robust clinical trial evidence. What about the real world effectiveness? So I think as we start to think about what are the next steps in the research as we go from clinical trial efficacy to real world effectiveness and implementation, is what is that heterogeneity of treatment and effect, specifically among people who are not included in clinical trials. And I think that representativeness question is really important. We know that the select population had less women than some of the earlier trials for weight loss, which was appropriate based on the ASCVD or CVD enrollment, but it does start to ask the question of, are we seeing differences there? So I think some of the things from a research perspective that might be helpful are there observational data sets that can help us inform the answer to some of those questions as these drugs become more and more accessible. So I'll pause there, and I'm sure there's lots of other thoughts and ways to address your questions and comments.
Maybe just to briefly weigh in on that as well. So at NIDDK, we have a major initiative right now focused at the heterogeneity of diabetes, which again, you would think we know a lot about, but we actually don't, and it certainly hasn't transpired down to the treatment regimens. Similarly, I think there will be a need for further studies of the heterogeneity of obesity. I think there have been attempts made, and we have some interesting suggestions out there in the literature already. And I think we will learn a lot about the individuals that do not respond to the same degree in this really widespread big experiment that's going on out there right now on the incretin side. So we will learn a lot. And not just from the responders, but I think we will learn a lot more from the non-responders, and that will probably pave the way towards a better understanding of the heterogeneity of diabetes. So I think that's a really good and important question.
I think age is a big one. I mean, I think a lot of people are concerned, even if somebody is, living with obesity, has a high BMI, if they're in their 80s or something like that. A lot of people are pretty reluctant that could cause some wasting, just the loss of, a lot of them have sarcopenic obesity, and you lose a little bit of muscle. So a lot of questions, I think.
And I would say there's still a lot of room to think about where does stress and psychosocial factors and environmental factors, where do those and how do those contribute to the heterogeneity of response. We had worked several years ago at NIH to start to think of some of those multi-level factors to include in weight loss interventions or studies of weight loss maintenance that relate to not only the biologic factors, but the health behaviors, the environment, and the social or psychosocial markers that may relate to heterogeneity. So thinking about how do we add some of those to the trials that have been done, I think would be important.
I think another thing to consider would be the obesity paradox, especially with reference to ethnicity. Would we see such, differences, for instance, in responses to these new agents? And again, I want to stress, sex differences, because the predominant mechanisms that, drive these cardiovascular effects, for obesity are different. What factors affects women, more than men, are different. So how do these treatments, affect the different pathways? For instance, would there be greater effects on inflammation, insulin resistance, as opposed to hemodynamic effects, which are bigger pathways amongst men, drive HFpEF, like Dr. Bullock mentioned, etc. I think those are the big things I think I would hope will be addressed in this.
Dr. Borlaug, I see your hand is up.
Yeah, I was just I was thinking about the heterogeneity of responsiveness to the incretins. And, we see some people just can't tolerate them at all. Some people seem to have a really exuberant weight loss with even very low dose of semaglutide, for example, and why. And then other people, that they're taking it as prescribed and they're following all the rules, but they seem to be just recalcitrant and they don't lose very much. So I'm wondering, and I'm looking at Dr. Linkoff. I'm not sure if you are looking at anything with SELECT, but I think you'd be the person to ask about this.
We didn't find clear predictors for weight loss effect. We didn't find much in the way of clear predictors. Echoing previous studies, women lose more weight than men. We didn't have patients with diabetes, so we couldn't really look at that versus non. But as you pointed out, and experience in STEP HFpEF is generally they tend to lose, patients with diabetes tend to lose less. Patients who were at higher weight to start with had a greater magnitude of weight loss, but often proportional or maybe somewhat more proportion. But so at least within the groups that we looked at, the predictors, we couldn't really identify much. We did see a clear correlation with the extent of weight loss and the extent of CRP reduction. So there's some linkage there, but not predictors of who would or would not respond. And it's a very complicated relationship, whether or not that actually relates to the cardiovascular benefits, which we're still trying to tease out. As I showed, the top line data for weight relationship to outcome and glucose or glycemia change with cardiovascular outcome seems to be weak, if not absent. And we're working hard to try to tease out and whether how that relationship is with inflammation. So, and we hope to have a publication soon on that.
And Sadiya, I see your hand up.
Yeah, I was just going to say, this is really interesting. It's almost like there's two heterogeneity questions. There's the heterogeneity of disease, as we think about obesity or diabetes being these really syndromes almost, I guess. Heart failure is very good at calling everything a syndrome and talking about phenogrouping. And I think that perhaps is what we're saying here, but also the heterogeneity of the response to the drug. And those may not be direct one-to-one, just because you have a certain subtype of obesity, you're going to have a certain response either.
And just following along with that topic of this seemed to be an underlying themes and interest of everybody in the audience for some of these treatments. Sadiya, you had brought up a point earlier in a discussion that I kicked until the panel. So if you wanted to introduce your question to the rest of your colleagues, that would be great.
Yeah, no, thanks, Eric. I know when Dr. Powell Wiley was speaking, and we've talked a lot about this with the AHA-CKM construct, how do we really change the framework that obesity is a chronic disease? And I think SELECT was really helpful for this too, in advancing this idea that treatment that targets weight management is not an elective treatment, but actually a treatment that prevents cardiovascular disease and shifts that framework from something that's elective or cosmetic to something that is necessary. And so I think that's the first part. And then the second part is really around stigma and psychosocial stressors related to treatment. And we see this in clinic frequently. People are almost embarrassed to bring up their desire to be on this therapy or if they qualify for the therapy. And conversely, in the public sphere, I don't know how many of you saw that South Park episode, but it was really targeting a lot of these, in a very exaggerated way. But I think important things to discuss.
Well, for my part as a cardiologist, I think part of dealing with the stigma to address the second part is for us to actively address it, so that it's not something that they have to wait for to build the courage, so to speak, or the impetus to bring it up, but to treat it as the same as we treat their blood pressure and by say treating, I mean address it in the same way we address their blood pressure and their cholesterol and their other risk factors. I see, and I'd say that's one end. And the goal would be, I think, obviously to move as far upstream as we can. That's that whole CKM continuum is such a nice conceptualization in my mind, because it really points out that an early causation is the overweight and obesity and the dysfunctional body fat, and that you don't need to wait till a patient has established cardiovascular disease. I mean, that's what we did in SELECT, but that's the first trial. But we'll have more evidence from the tirzepatide trial, which is going to have high risk primary prevention. And I think most of us anticipate if it works for secondary, it's going to work for primary. The question is how to do that in a way that's economic and cost effective. But those are other issues. And then to me, the other question, because it is a chronic disease, is what are we going to do long term? Because we really haven't looked at that. On the face of what we have now is you continue the medication. I mean, they'll reach their plateau. We have no evidence, just as we don't for LDL or for blood pressure, that if you come off the medication, you're going to retain the cardiovascular effect. But do we really need to use the same doses of the medications? So I know that some practitioners are experimenting with, a lower dose, a maintenance dose. Maybe that'll work. you'll have some biomarkers that you can test. You can see if they maintain their body weight, for example, but that may or may not actually correlate with a cardiovascular benefit. I think we're going to need to investigate that. As a first round, you can't do that. You need to prove that it works in reducing the outcomes. But once we establish that and are comfortable that it's with a variety of drugs that work on a common mechanism, I think we're going to need more investigations on what's the optimal way to use this long term, because we're only putting a Band-Aid if we're going to treat patients for 2.5 or 3 years. We really have to figure out strategies to treat patients long term.
And so to get to your first questions, Sadiya, around the how do we discuss this as a chronic disease, or how do we move away from making this about cosmetic appearance and things like that? I think we need to have more of a discussion about how obesity relates to adiposity, and it's really about treating adiposity as opposed to treating size, or a body size, a body weight, and getting to a certain weight, and it's not about getting to a certain weight. It's about treating dysfunctional adiposity, and reducing inflammation, and utilizing these medications or these treatments to improve the functions of what is happening or related to adipose tissue, as opposed to making sure that you fit a certain size clothing or things like that. And I do think there is, as was somewhat highlighted by the South Park episode, there's a backlash in thinking about this expectation that you are going to look a certain way based on these medications, and you're supposed to look a certain way based on these medications. And there are many people who don't want to look that way, and that should not be an expectation. It should really be about improving their health.
Great. Kind of following up on that, one of the other big themes, and of course, as a physical activity epidemiologist, this comes up, is the role of lifestyle and behavior, in addition to some of these other ways that we're approaching treatment. And specifically for me, thinking about the fact of, to say the least, that population behavioral interventions are challenging, and adherence is very challenging, but we often do this with one general recommendation or guideline. And so do you see this being different based on the condition or the disease that we may be targeting, whether that be in terms of aging or diabetes versus other types of chronic diseases? And how do you kind of see that playing in as we move away from the main goal of exercise being to lose weight? So how do we sort of shift that public perception as well?
I think I'll start, I guess, Eric, that's a really great point. I think generally our approach to lifestyle behaviors as not just for the means of weight is really the framing. And I think Tiffany did just had a really nice approach to, I think, how we want to frame it. That physical activity, lifestyle, fitness, all of these things are ultimately for the end goal of cardiovascular health. And perhaps the CKM construct helps to affirm that, but it's challenging, I think, because it's this two-part, and I think with weight too, whether it's diet, physical activity, it's the maintenance. Initiating and intervening, even as hard as those are, almost seem like the easy thing. How do you persist or maintain those interventions?
So I would argue that even with lifestyle, it is about helping patients to understand that there are not just benefits around body weight, around losing fat mass, but also it's about reducing stress. It's about improving sleep. It's about improving your day-to-day, how you feel in your day-to-day life. And so these are ways in thinking about how do we reframe how we talk about like not only obesity, but the lifestyle changes that are required to treat obesity, and then how do we advocate for those, if not just in terms of as treatments for obesity, but it's really treatments for cardiovascular health.
Dr. Ebong?
Thank you. I'm just wondering, with more and more weight loss medications being available, what's the role of bariatric surgery? And at what point, do we wait, how many, the degree of obesity, because we are not talking a lot, we're not discussing, bariatric surgery as much as, we used to before these drugs came about.
If I can weigh in there, I think it's actually surprising that there is a resurgence of bariatric surgery at this point, even though we all predicted this is the end of bariatric surgery. And the reason is simply an economic one. At this point, from an insurance perspective, you have foot the bill for a bariatric surgery, which at this stage is somewhere between 20, 25K, not for the follow-up, versus what looks like a lifelong exposure to the incretins at somewhere $12,000–15,000 a year. So the basic economic calculation ends up actually being a simple one, because it turns out that bariatric surgery is actually the cheaper option at this point. So that's why I think the bariatric surgery clinics have more business than ever before at this point. And this is all probably payer driven at the end of the day.
I think that's really interesting. And thinking about that in kind of payer, and unfortunately the way the world really works, of going back a little bit more to my cardiac rehab days and arrhythmia days, of where exercise tends to be a little bit more prescriptive in terms of how we're addressing these things. How do we see that kind of changing some of that kind of mentality, where sometimes it's already hard to get people into cardiac rehab or to pay for cardiac rehab? Now, how are we trying to think of that as part of an active treatment, I guess, as well as just a population exercise is good, so what, that I usually have to give that lecture on? Any thoughts from that, where it tends to be more prescriptive in a secondary type of environment?
Well, in my limited experience, we do actually have a pretty good rate of sending people and getting people to go to cardiac rehab after an event, after myocardial infarction, a stent, bypass surgery, et cetera. There's many advantages, but the major disadvantages, or disadvantage in my regard, is that they eventually fade off. I mean, it's a 9 to 12 week course, and that's it. And as much as they try, and we try to reinforce the idea that this is a lifetime change in behavior, they look at it, many patients look at it as sort of their recovery or rehab from the problem that led them to the surgery, the rehab in the first place. So, I certainly doing this as part of, an initial management or even medical management of their vascular disease or their metabolic disease, I think makes sense. The question, as you point out, is how do you get that paid for? And again, how do you extend it? Because this is the problem with all of these lifestyle modifications. How do you extend it over long term? Even an intense period of 3 days a week rehab for 9 to 12 weeks, and yet the attrition is remarkable in most of these patients.
Dr. Ebong, was that a old hand or a new hand?
I think it was an old hand, but yeah, just in response, second to that, I agree. I think the problem with cardiac rehab is really the cost, particularly for the patients with HFpEF, that we know. I mean, we have data that says that people with HFpEF do benefit a lot from weight loss, even, more significantly than people with HFrEF. And occasionally, I've had some patients, pay out of pocket, to get into programs, but we can't gauge the effectiveness of those programs. And then, of course, the long-term ability to keep exercising, I think it's very limited for somebody with HFpEF who has difficulties in exercising anyway.
And I guess I would just add to that. I think I'm a little more of a glass half empty person than I think Dr. Linkoff. I think nationally the cardiac rehab rates aren't great. And so I think, Eric, you bring up a really great point of, is there a way to think about implementation strategies that are more holistic in terms of secondary prevention. So is there a way to pair cardiac rehab and semaglutide after an event that allows somebody to have better adherence to both, or figure out ways that we are coming up with strategies that are more holistic for diet, lifestyle, and other interventions as well.
Great. And in the chat, we have a comment that's echoing a lot of this, of thinking about language and how we address obesity as a risk factor from a personal level as well. So I think that we really have seen some of that. In the last few minutes, I want to talk a little bit about access, one of the big elephants in the room of these things, and how technology may or may not be able to help with that. Not necessarily just from exercise with my accelerometers and everything, but just obesity or weight management, especially with or without medication, of how you really see us being able to reach other people, especially when they won't be able to come into the clinic or we can't get them that way, of how really can technology and other things kind of move this to the next stage, if it can.
So as I mentioned in my talk, we certainly have evidence that, there's technology out there that will be effective in weight loss and improving weight loss. The question becomes, what do those types of digital health interventions look like in weight loss maintenance? How should they be utilized in weight loss maintenance? How should they be designed specifically for populations who are most affected by health disparities? We have some data that shows there are interventions that can improve physical activity, that can reduce that can improve diet using technology in diverse populations. But there's certainly room for additional studies that look at ways to develop those types of interventions.
Thanks. In the last minute, what research question and hopefully answer is coming down the pipe quickly that you are most excited to be able to see? So one of the upcoming studies, or what's the next question that you really want to kind of sink your teeth into, or get the crowd a little excited by, if this may be what's next for us to look forward to?
No, it seems like a really tough question. None of us have answers to that, but I think if in terms of what's coming up next, you can have your finger on the pulse of what's going out there in big pharma and biotech. And at this point, nobody tries to compete with the incretins. And the major effort is basically trying to find the ideal combination therapy on top of the incretins for whatever it is that you're specifically interested in. And I think what's changed now versus the basic philosophy of 5 to 8 years ago is that combination therapies are absolutely acceptable. And you can mix and match pretty much in any way you want, which is something we wouldn't even dare to think about in not too long ago. So I think it's exciting to see which particular combination will work best for a specific aspect of that cardiorenal syndrome that we're talking about. And I think it's exciting to just see how fast we're moving. Next 1 or 2 years, it'll be really cool to see what's coming down the pipeline there.
I think I'll add to that. I think moving into primary prevention is really exciting, as Dr. Linkoff mentioned. Secondary prevention was the place to start, but being able to really see how we can maximally have impact on a population level. And as a preventive cardiologist, perhaps I'm biased by that too, but I think that's where the majority of the impact is going to be.
And I'll be very interested in the outcome trials of these multiple different receptor incretins. Because the proof of concept here is, it's like the LDL meta-regression. Will we find ultimately that drugs that cause more weight loss improve cardiovascular outcome more, or will we find there's a dissociation? Either answer will be fine. It'll help us guide maybe selection of patients and what drug we want to use in which situations. But to understand sort of the principle here, because although we're trying this with select trial, you can never make a meaningful mediation analysis with a single trial, because anything you're mediating is a post-randomization variable. So at the very fundamental level, it's impossible. We can make hypothesis generation. It's only when you have multiple trials that have different effects on different parameters that you're interested in with different agents that you can then begin to see which, if any, correlate, and if so, how much. So from the scientific standpoint, I think we can learn more about mechanisms and, as I say, practical applications once we have more trials with different agents.
And Dr. Ebong, maybe one more to close out the question.
Yeah, very brief. I think I'm very interested in looking at sex-specific treatments. I don't necessarily believe that what would work for men would work with the same efficacy for women. I think that needs to be looked at.
All righty, well, thank you all very much, and I'll leave it to Sue to close us out.
Sure. I just want to thank again all of our speakers and moderators in the audience that asked such great questions. And again, we will let you all know when the recording of today's symposium is posted. And I'll thank you again and goodbye.
Thank you, everyone.
Thank you.
Thank you.